All phone lines have been muted. If you need technical assistance during the meeting, please type the issue into the Q&A box and one of our techs will respond to you. Please note that this meeting is being recorded. I will now turn it over to Jennifer Bishop.
Good afternoon. My name is Jennifer Bishop, and I am the designated federal officer for the National Clinical Care Commission. I would like to extend a warm welcome to the participants and audience of the 7th meeting of the Clinical Care Commission. Before we begin, I'd like to acknowledge 2 individuals who are new to working with the Commission. The first is Dr. Richard Olson, who is the new technical lead for the Clinical Care Commission, and also the director of the Division of Prevention Science within the HHS Office of Disease Prevention and Health Promotion within the Office of the Assistant Secretary for Health. Additionally, although not pictured but present at our meeting, I would also like to acknowledge Captain Paul Reed. He is the Deputy Assistant Secretary for Health of Medicine and Science and the new Acting Director of the Office of Disease Prevention and Health Promotion in the Office of the Assistant Secretary for Health within HHS. Thank you both for being part of our team. I will now begin the meeting with a roll call of the Commission members. Please reply present when your name is called. Bill Herman.
Present.
Ann Albright.
Present.
Howard Tracer.
Present.
Barry Marks.
Present.
Naomi Fukugawa.
Present.
Donald Schell.
Present.
Bill Chung.
Present.
Aaron Lapata. Aaron Lapata. Ann Bullock.
Present.
Barbara Linder.
Present.
Captain Samuel Wu.
Present.
Paul Conley.
Present.
Ayatendi Doken.
Present.
Carol Greenlee.
Present.
David Strogat. David Strogat. Dean Schillinger.
Present.
Ellen Leek.
Present.
Jasmine Gonzalvo.
Present.
John Boltry.
Present.
Meredith Hawkins.
Present.
Shannon Fizzik. Sharon Isaac.
Present.
Excuse me, Shannon. Thank you. Shari Bolin.
Present.
And Bill Cook. William Cook. Okay. And just to look back, Aaron Lapata. David Strogat.
So Jennifer Bishop,
Yeah.
they're both present and they have acknowledged in the chat area.
Thank you. I'm pleased to announce that we have a quorum, and I will now turn the meeting over to Dr. Bill Herman, the National Clinical Care Commission Chair.
Thank you very much, Jennifer. I too want to welcome you to this virtual meeting of the National Clinical Care Commission. As you know, the Commission's activities have been coordinated by 3 subcommittees, the first focusing on diabetes prevention in the general population, the second on targeted interventions for diabetes prevention, and the third on diabetes treatment and complications. We are also focusing on cross-cutting issues related to health equity, social determinants of health, and research needs. Since our last meeting, we've reviewed information provided by federal agencies to the Commission, information from key informants, and information from literature searches. Today's agenda will focus largely on updates by each of the subcommittees with discussion by the members of the Commission. At this point, I'd like to turn things over to Clydette Powell for a further update on the data call from the various federal agencies. Clydette?
Good afternoon. Are you able to hear me?
Yes.
Do we have the next slide, please? The process of receiving public comments for the National Clinical Care Commission is displayed on this particular slide, and it's a simplified version, but I would just like to walk through it briefly. At the request of the National Clinical Care Commission, our Office of Disease Prevention and Health Promotion drafts a Federal Register notice, which informs the public of meetings and also solicits requests. That is sent then to the Federal Register, which is placed for the public to review, and the responses are gathered through this system, and comments are posted on regulations.gov so that they can be reviewed. Federal agencies use the Federal Docket Management System to post the FRN to regulations.gov and to manage comments. The public is able to see the Federal Register notice, read the comments, and submit documents. Next slide. So within the Federal Register notification, 5 key questions were submitted for public comment. These were provided, as I mentioned, through the Federal Register notice for public comments between January and the end of March of this year, 2020. These questions ask the following about federal programs in diabetes prevention, care, and treatment. So within the area of the context of our programs, the specific question was, what social, economic, and or environmental factors have the greatest impact on healthcare in general, and also on the prevention of type 2 diabetes and or the management of diabetes type 1 and type 2? What can be done by the federal government to address social, economic, and environmental factors? The second question posed through the Federal Register for public comments was focused on policies. What policies should the federal government implement to improve diabetes prevention and or management? What is the evidence to support your comments? The third area explored effectiveness. What specific recommendations do you have for the federal government to be more effective and to collaborate better to prevent and or help manage diabetes? What is the basis for your recommendations? The fourth question asked about promising practices. What are the best and most promising practices to prevent diabetes and or to improve diabetes outcomes? What is the evidence to support these? The fifth and last question for public comment was, what are the limitations and gaps? What can the federal government do to close these gaps? What are the specific research needs or programs that would benefit from new or increased collaboration across the federal government? 84 replies were received. Respondents represented U.S.-based professional organizations, both primary and specialty care, practices and systems, as well as individuals impacted by diabetes. Next slide. The stakeholder public comments fell into various categories, which are shown here and in the next couple of slides. Within regulatory reform, the public commented on barriers to diabetes self-management training under Medicare and other plans. There were comments on taxes on sugar-sweetened beverages, negotiation on drug prices, especially the cost of insulin, and the request for faster approval for new technologies for diabetes. Under federal reimbursement and payment reform, there were comments focused on improving reimbursement for services such as diabetes education and timely reimbursement for new devices and technologies. Next slide. There were also comments about school food programs in respect to the need for healthier meals offered to students and the importance of earlier education, for example, at primary school level, about healthy choices and better food choices at school. Within diabetes education, many comments focused on access, uptake, and expansion of diabetes education programs. They also requested longer periods for diabetes counseling services and expanding the pool of referring providers, as well as allowance for concurrent services. With regard to healthcare providers, there were requests and comments regarding extending the roles beyond physicians to nurse practitioners, pharmacists, for example, and even health coaches. In addition, improvement of referral rates for diabetes self-management programs. Next slide. Many comments focused on nutrition, such as counseling and education, advertisements about food content and labeling, individualized medical nutrition therapy, dietary guidelines, and a whole host of dietary approaches to obesity and prediabetes. There were also comments about the social determinants of health, such as community services for people and families affected by diabetes, especially in remote, rural, and underserved areas, access to sport at schools, and comments about the inequities, such as the digital divide, where virtual and digital solutions might not be accessible to some populations. I will now move on to an update on the federal data call. Next slide, please. This infographic shows in a simplified form the process of the federal data call that occurred last year and into early 2020. The Commission drafted and approved a data call, and this data call was signed by the Assistant Secretary for Health and sent to the chartered agencies, that is, the 11 agencies that are represented on the Commission, and shown in the third circle there and represented by the members on the Commission today. Those agencies reviewed the federal data call and sent those responses back to the Office of Disease Prevention and Health Promotion. There, and with the work of our contractor and subcontractor, the responses were organized for subcommittee review. The National Clinical Care Commission is in the process of using these responses to inform the work of the subcommittee and the full commission and to inform the final report. Next slide. As I mentioned, the federal data call was sent to those federal agencies. There was also a request made to the Bureau of Prisons that has programs for the population that they serve who have diabetes. And information has also been solicited about programs, policies, and research. Given the streamlined process and version of the data call, supplementary information was provided to the National Clinical Care Commission at their request. So the full November 2019 Commission meeting was devoted to social determinants of health. And then earlier this year, a half-day session was dedicated to presentation and discussion regarding the Centers for Medicare and Medicaid Services, their coverage and reimbursement. The subcommittees began reviewing the data call responses in March of this year and is still in the process of reviewing and synthesizing these to inform their work and ultimately their recommendations. These data call responses will be incorporated in some fashion into the final report to Congress and to the Secretary of Health and Human Services. I believe that is the last slide on the federal data call, and I will hand this over to our two co-chairs, Dr. Ann Bullock and Dr. Dean Schillinger, who will represent the work of the subcommittee called the Prevention for the General Population. Thank you.
Thank you, Clydette. This is Ann Bullock. It's a pleasure to be with everyone today. Dean Schillinger and I are happy to do this presentation. We will tag team it here as we go through. So, as Clydette said, we are the first of the three subcommittees to present on our work to date. Ours is charged with looking at prevention issues across the general population, prevention of diabetes for sure, but also similar issues are applicable to prevention of complications of diabetes as well. So we'll be glad to let you know about who our subcommittee members are. In addition to Dean and I, the non-federal members of our panel or special government employees are listed there. And the other federal members of our subcommittee, in addition to myself, are on this slide. I appreciate everyone's expertise and help with all of the work, including the development of this presentation. So what we will be talking about today is, of course, to talk about where the General Population Subcommittee is. We often call ourselves Gen Pop for short. So we'll talk a little about how our work is framed. We will talk about the overall Commission's Diabetes Prevention and Care Model and how our discussion today comes out of that. We will talk about the results of the federal data call which is what Clydette just discussed, and of course how this, we're looking at how it's relevant to our subcommittee's work, and to be clear that there is much more that came from that data call than what we will be talking about that will be relevant to the other subcommittees. We'll talk about the key informant call just briefly, and then we have already started on the work in two very key focus areas, and Dean will talk about these two. First one is on health impact assessments, and the second on diet and nutrition. We will be developing other focus areas as our work progresses, but these are the two that we have started with and which we'll present on today. We'll discuss our next steps and then, of course, also frame our work now with the current issue of COVID-19 and how that is bringing out issues around health equity, particularly around diabetes and poverty and many other issues, and how intersecting these are and how much they are highlighting each other. So with that, just a few quick considerations, since our work and that of the Targeted Population Subcommittee might not seem immediately intuitively obvious. The Commission determined that things like screening for diabetes and then individual level prevention programs, those are very important, but because they are targeted and differentially applicable to different parts of the population, that is the work of the Targeted Population Subcommittee, who will be discussing their work next. And as I mentioned a minute ago, because the majority of opportunity for prevention currently is on type 2 diabetes, we'll talk about that. But while things that help prevent type 2 diabetes are particular to it, but those same kinds of things often help those who have prediabetes, those who have type 1 and type 2 diabetes, as well as those dealing with diabetes-related complications. So with those considerations, our framing statement for our subcommittee is here. I know it's a little wordy, but we'll just go through it quickly. The type 2 diabetes epidemic in the United States has emerged largely as a result of rapidly changing social, environmental, or structural factors that affect individual behaviors and exposures, such as things like physical activity, dietary choice, and so on, but also much larger issues, including economic opportunity, stress, and other kinds of social determinants and other kinds of related issues, stress, discrimination, food insecurity, many of these things. Our subcommittee recognizes these factors and exposures are differentially and unequally distributed across the population based on socioeconomic, racial, ethnic, and geographic characteristics. And further, that such exposures have differential impacts at different points, both within particular time points, but also across the whole life course, that these risks accumulate meaning through the life course. And finally, the subcommittee recognizes that diabetogenic exposures and associated interventions to reduce diabetes risk are determined by multi-level processes. Yes, it's about individual behaviors, but it's also very much about the context for those behaviors and the larger structural issues that create many of the diabetes risk factors that we have started to understand in the last couple of decades. As such, this requires that we approach type 2 diabetes prevention from a socio-ecological perspective, which we'll talk about in just a moment, with effective and scalable interventions and solutions that play out at the local level, for individuals, families, and so on, but even more so looking at larger population kinds of issues. We have to look at different settings that affect those levels and in a fashion that is at times broad-based, as we're saying, and also tailored to certain high-risk groups because, again, these risks are not equally distributed across the population. So this next slide is the Commission's model for diabetes prevention and care, the way we are framing our discussion of all of the Commission's work. This is a hybrid of several existing models, including the chronic care model. So this will look informed, familiar to those who know that model. But it also has some other components added to it. What our subcommittee has done for this presentation is to put into red font the issues that we will be talking about today and many of the issues that our subcommittee is working on overall. So indeed, public policy at the top, and also food systems, government, industry, communication, and marketing today. But in the future, we will be looking at all of those sectors of influence, as they're called there. But today we're highlighting those in red font. And then individual factors, obviously diet and physical activity, but as I've already talked about, stress and the associated issues of trauma and other psychosocial factors, all with the hope of, on the bottom left, helping the population to be more immune, if you will, to diabetes, and also because supportive policies, social conditions, and environments have been engendered through different changes in policy. So with that, looking at the relevant federal agencies to this work, obviously it's huge when you take this larger lens to realize that all kinds of policies really are health policies. It makes a much bigger picture of the type of agencies that one might want to talk to. Yes, there are all of that list on the left of traditional associated health agencies, CDC, NIH, HRSA, FDA, ACF, Office of Minority Health, We and Indian Health Service, or IHS, the VA, CMS, and AHRQ. Those all have obvious connections to health. But because we're looking at this much larger socio-ecological picture, we need to talk to people who are involved in many other types of federal policy, including that which affects food and transportation, education, and so on. So what we're calling non-health in quotation marks here, only because these agencies work or not probably for most people thought of as health-related work, but indeed, absolutely, this is all related to health. So, as I mentioned, USDA, many things related to food policy. Department of Transportation, is transportation active? Does it create pollutants in the air, which are disproportionately affecting communities of poverty and affect things like diabetes risk in a multitude of ways? Department of Education, not just are we teaching about diet and exercise, but are we also providing good foods in the schools? Are we also just improving education rates in general, because diabetes risk has been associated with level of education and socioeconomic outcomes from that. Federal Trade Commission on how products are marketed, Department of Labor in terms of jobs and wages, EPA, because there's so many pollutants that have been shown to increase risk for things like diabetes and obesity, the FCC on how, not just on marketing, but on communications, on how that is working. Our colleagues at the Department of Defense have a lot of health programs, of course, to take care of military members. Department of Treasury around taxes and other things, earned income tax credits, et cetera, that affect issues related to poverty. The Bureau of Prisons and the care for people within those prisons, both their health care, but also how well are they being prepared to come out and be good parents and be able to handle the stresses and difficulties in their lives better. And then, of course, housing and urban development we know housing has a huge impact on many issues related to diabetes, including risk factors for diabetes itself, quality of neighborhoods, et cetera. So a lot of things to take into consideration as we're looking through this lens of the socio-ecological model related to diabetes. So in our review of the federal data call, and as I said a few minutes ago, we were only looking at the section of a data call that would relate to these kinds of issues. And however, the questions in the data call were pretty specific to diabetes and traditional diet and exercise, medications, and other kinds of things that people associate with diabetes regularly. So many of our agencies here, you'll see notations of programs they didn't tell us about on the data call, but that we're aware of. So we want to make sure that's clear, that we appreciate all of the responses from all of the agencies and want to learn about and highlight the work that they're doing in these important ways, and also, of course, use this opportunity for the Commission to recommend, strengthening of things that could help us in this larger perspective. So our colleagues at CDC, we talked with us about, on the data call, about some promising programs, including the REACH and LEAD and NOPREN programs, which you can look up, but all relate to population-level diabetes issues, some policy-related natural experiments, a new request for applications for a new grant program related to that, and responses related to promising other programs, including Health for All policies, something that Dean will talk about in a few minutes, and other kinds of things were not identified or described in the data call, but we know there are a number of people at CDC working on that. And as you'll notice from the asterisk, we'll be following up with many of these agencies to learn more. Our colleagues at NIH, the National Institutes of Health, identified a number of promising programs, including some translational programs, but noting that the research that they discussed there is overwhelmingly at the cellular or even subcellular molecular level, and to a lesser degree at clinical translational levels, and not much at the population level. They didn't provide us information here on diabetes policy evaluation, population level interventions, or including things like simulations and health economic modeling to look at population level research. So we will be following up with them to learn more about those issues, including some of the nutritional research and other things that are funded in different parts of NIH and different institutes. Colleagues at HRSA, Healthcare Resources and Services Administration, responses, again, focused really on diabetes as the questions in the data call really led people to focus on. But there are many wonderful, promising programs at HRSA which impact upstream risk factors along the life course. Maternal, infant, early life home visiting programs, maternal and child health block grant programs, the Healthy Start program, programs related to child care standards. These are all very important issues to this larger socio-ecological and life course model that we're working from. And so we are following up with HRSA. Already have talked with Maternal Child Health Bureau on some of this, and we'll be looking for more because there's some very exciting programs we would love to highlight going forward. Colleagues at FDA, Food and Drug Administration, again, they focused in their responses and the data called on therapeutic and monitoring functions like medications and devices, which are certainly important. But in terms of looking at this larger picture, their responses didn't look as much at things like alignment with the U.S. dietary guidelines and nutrient content and labeling and other kinds of things. So we are following up with the FDA. Our IHS response is still pending, so won't comment on that. One more slide on data call. There were a lot of responses from different agencies. The Office of Minority Health did not give us anything in that was related to this larger model. I'm sure things helpful to the other subcommittees. ARC, sort of a similar, nothing that came relevant to our subcommittee. VA, their, again, responses focused on individual level programs, but we know the VA is doing many things related to food security and housing security issues for veterans, and we're looking forward to learning more about those programs as they do many things to assist our nation's veterans. CMS, again, focused on individual level prevention, treatment, and their responses, and we're looking forward to hearing more about any trans-sector collaborations, like with transportation, housing, or other kinds of larger population-level issues. Department of Defense has an MNEAT tool, a military nutrition environmental assessment tool, which does look at the nutrition environment for military members, so looking at the population level. USDA, there are many programs in USDA that were discussed in the data column that we're aware of and that we are enthusiastically learning more about, including the school lunch program, school breakfast programs, WIC, SNAP, the Fresh Fruit and Vegetable Incentive Program. These are all very important programs for helping to improve nutrition, reduce food insecurity, and the stresses that are associated with that. Population level impacts weren't discussed there, but we are following up with USDA to discuss this further. So this next slide is just a listing of some of the key informant stakeholder calls that we've had so far to learn more from some of these, and many more are yet to come. So with that, I'm going to turn it over to Dean to talk about the two focus areas that our subcommittee has already begun work on. Dean?
Thank you, Anne. As Anne said, what she provided really is a review of the background work that we've done leading up to today's call, and I'm going to focus on two priority focus areas that will stimulate hopefully some discussion amongst the commission members in the last 20 minutes and beyond. We're going to focus on two aspects of our work. The first is advancing a health in all policies approach across federal agencies in areas that are relevant to diabetes. And the second is to share some of our work in the domains of diet and nutrition, which primarily are relevant to USDA and FDA, but also have additional relevance to other agencies where diet and nutrition is part of their service mission. So focus area one, which is about health impact assessments. I just want to take one step back and remind everyone that this tool of health impact assessments was generated out of approach to governance, an approach to planning and policy making at both the governmental and private sector setting, and it's known as health in all policies. And health in all policies is a collaborative approach that integrates and articulates health considerations into policy making across sectors to improve the health of all communities and people. Health in all policies recognizes that health is created by a multitude of factors beyond healthcare, and in many cases beyond the scope of traditional public health activities. The health in all policies approach provides one way to achieve the National Prevention Strategy and Healthy People 2020 goals and enhance potential for state, territorial, and local health departments to improve health outcomes. The health in all policies approach may also be effective in identifying gaps in evidence and achieving health equity. The National Prevention Strategy provides a health in all policies framework to guide our nation in the most effective and achievable means for improving health and well-being. So while the federal government has actually, in this case you'll see the references from the CDC, has taken a lead in disseminating the importance of a health in all policies framework, by and large, the federal government is providing recommendations to local municipalities, local health departments, and state health departments to integrate this construct into their work. And the federal government, by and large, is not beholden or has not embraced the health in all policies approach to policy making, particularly with respect to non-health sectors, which is what is the focus of our discussion today. Now, health impact assessment, as I said, which emanated from the health in all policies construct, is a systematic process whose goal is to promote health in all policies. HIAs use an array of data sources and analytic methods and consider input from stakeholders to determine the potential effects of a proposed policy, plan, program, or project on the health of a population and the distribution of those effects within the population. Health impact assessments can also provide recommendations on monitoring and managing those effects once the project has been approved and implemented. HIAs can be useful to promote health and mitigate adverse impacts of decisions made outside of the health sector. In general, the effectiveness of health impact assessments are measured across three dimensions. Primarily their health effectiveness, the extent to which the process led to policies that avoid negative health effects and strengthen positive health effects. The equity effectiveness, assessing and preventing disproportionate impacts on vulnerable populations. And the last element is community effectiveness, the degree to which the health impact assessment process incorporated a community's interest into the decision process. These health impact assessment models have been thoroughly vetted and reviewed and are the subject of a number of Institute of Medicine, now known as the National Academy of Science, Engineering, and Medicine publications, and is widely accepted as a standard in the public health community. The domains of health impact assessments in terms of the kinds of projects that historically they have been applied to has been the subject of a number of recent reviews. And I present them here in the order of highest frequency to lowest frequency. And as you will see, many of them have direct relevance to the work of diabetes prevention and control at a population level. These include most commonly land use decisions, transportation decisions, and decisions around the built environment. To a lesser extent, housing, industry, and this relates to a term that is becoming popularized now around the so-called, quote, commercial determinants of health, end quote. Plans regarding leisure activities and stadiums and that sort of thing, urban planning, waste management, natural resources and environmental issues such as water access, and then lastly, interestingly, least commonly, agricultural decisions and policy. A recent review of health impact assessments carried out at the local and state level has been performed that captured health impact assessments over the decade listed here and involved a review of about 200 completed health impact assessments that were associated with policies and projects. And I just here am highlighting selected findings from each of these reviews that I think will provide insight into the discussion that we will be having on the NCCC's potential to make recommendations with respect to health impact assessments. Wismar et al. Found, importantly, that as opposed to popular belief, health impact assessments in no circumstance led to the cancellation of a project, implementation, or completion. Rodas found that health impact assessments almost always facilitated novel interdepartmental, intersectoral, and interagency collaborations. And insofar as that interagency collaboration is one of the primary objectives of the NCCC, I wanted to make sure that I called out those findings. Second, Rodas found that evidence for direct effectiveness, here meaning that the health impact assessment itself led to health-promoting changes in the program itself, was observed for a majority of health impact assessments, 60%. In addition, general effectiveness, which is, has been defined as leading to a greater awareness of health impacts among policymakers and the public, was seen for an additional 32%. Hague found that 91% of survey respondents reported that health impact assessments actually impacted the decision-making processes and outcomes. 83% of those projects that had a health impact assessment reported that recommendations were easily incorporated and implemented into the project, and many health impact assessments helped legitimize involvement of the health sector into non-health sector decision-making. Boursier, who surveyed the actual decision-makers, those who were in charge of the policies and projects, found that 48% of decision makers reported that health impact assessments affected their ultimate decision. And specifically, they felt that they institutionalized or strengthened existing relationships between individuals and organizations, sometimes creating new and enduring relationships between public health and non-health agencies, and that they amplified community voice in decision-making processes. And finally, Davenport pointed out that effective health impact assessments needed to fit into political and administrative environments in which they are conducted, that these cannot happen in isolation. Now, along those lines, the factors associated with health impact assessments have been reviewed systematically by Dannenberg, who was one of the key informants that we heard a presentation from. And I've listed here those factors that are associated with the success of health impact assessments, specifically here, the degree to which they inform decision-making in health-promoting ways. The first is the importance of engaging the appropriate stakeholders. The second is having adequate resources, specifically time and staff, with which to conduct the health impact assessment. The third is timeliness of the health impact assessment results. The fourth is having sufficient policy and system support in place, such as frameworks or legislation supporting and following established HIA guidelines, as well as requirements to consider the HIA findings into subsequent planning and execution. The fifth was having available relevant data in a timely fashion, as well as the expertise to provide quantitative health and economic projections. Dannenberg pointed out that many health impact assessments have qualitative conclusions with statements such as, "We believe such a change will improve the levels of physical activity of the population," whereas others with more sophisticated expertise were able to actually quantify the degree of improvement and model the extent to which that might decrease incident disease or complications of disease and the downstream costs. Next was the importance of engaging the right people on the health impact assessment team, especially health economists, community representatives, urban planners, and business stakeholders. This is not simply an activity involving public health people, by no means. Next, recommendations needed to be clearly articulated and feasible for them to be implemented and have the intended effect. And finally, those recommendations and presentations of messages needed to be tailored to the needs and values of decision makers and other audiences. So with that review of health and all policies and what we know about health impact assessments, I've listed now some discussion questions that we can proceed to in a moment regarding health impact assessments for the National Clinical Care Commission to consider. First, just to summarize, health impact assessments should be part of the active toolbox of federal agencies' decision-making processes, especially as they relate to the social sector drivers of type 2 diabetes. So that's a statement to consider. The second, doing so in a consistent and streamlined manner could have tremendous potential to better prevent and control type 2 diabetes at scale. Obviously, policies and decisions that affect tens of millions, hundreds of millions of people, even if they are only incrementally beneficial with respect to preventing or controlling diabetes, can have massive effects at the population level. The NCCC, therefore, should consider whether we should recommend the establishment of requirements at the federal level to perform health impact assessments, whether there needs to be a process to establish the conditions and the circumstances under which health impact assessments should be performed, establish or select an entity or entities to conduct health impact assessments, provide resources to generate these health impact assessments, establish the mechanisms to adjudicate and implement the recommendations that emerge from health impact assessments, support the training of a highly skilled and interdisciplinary workforce to build the needed capacity to carry out health impact assessments, as currently this is a niche area, and the ability for health impact assessments to adhere to health impact assessment guidelines is often a function of the skill set of the workforce involved. And now on the research front, that we consider that the government fund rigorous evaluations of natural experiments that are going on in the diabetes policy domain, that can inform future health impact assessments. This is important because health impact assessments are a prospective exercise of predicting what the possible outcomes of certain programs and policies may be, and the extent to which natural experiment data can be harnessed to inform those projections cannot be overstated. And finally, more research is needed to enable the maximal degree of precision and robustness of health impact assessments in this quantitative fashion that I described earlier, including not only the health impacts of policies, but also their cost effectiveness within the health impact assessment and simulation research. And by cost effectiveness here, I'm not just speaking about the implications for healthcare costs and indirect costs related to healthcare expenditures, but also the economic consequences for the policy itself in non-health sector settings. What would be the impact on the business? What would be the impact on traffic, et cetera? So those are some discussion questions that we can discuss among others. And let me now move around focus area 1, which is the health impact assessment. Let me quickly move to focus area 2, which involves diet and nutrition, and remind people that 85% of total U.S. healthcare expenditures, more or less, are related to the management of diet-related chronic diseases such as type 2 diabetes. It has been estimated that the total annual direct and indirect costs for all obesity-related conditions is over $1.5 trillion a year, with $327 billion being attributed to the care, the indirect costs and direct costs of diabetes alone. So remember that $327 billion number, as the annual cost of diabetes itself dwarfs the annual budget appropriations of most federal departments and agencies as of fiscal year 20's budget. USDA is $150 billion, Department of Education is $72 billion, et cetera, et cetera. I think when you add all of those up, it's still less than the annual expenditures related to diabetes. By comparison, the largest budgetary agencies, of course, Department of Defense at $720 billion and CMS at $837 billion, when combined, are about the direct and indirect costs attributable to obesity-related conditions. The point being that unless we develop more robust and effective means of engaging the stakeholders that are responsible for what gets put on our plate, we will have a tough time bringing these costs related to diet-related diseases such as diabetes in control. So the key problems we have identified in the diet and nutrition domains after our informal literature review and our key informant interviews include the following. In the United States, there are high levels of consumption of foods and beverages with excess added sugars, simple carbohydrates, refined grains, calorically dense and high glycemic load foods, and sugar sweetened beverages. The consumption is both at a high level and prevalent, a high level in subpopulations and prevalent across the entire population. The consumption of less healthy foods is actually promoted by unfettered marketing and advertising, often by inaccurate or false health and nutrition claims, nearly always low costs relative to healthier foods, and easier access in numerous settings, especially in lower income neighborhoods, changing social norms, attributes of and regional and local differences in the retail food environments in which people live, and a general absence of clear and persuasive communications regarding what to avoid. In addition, the modern U.S. food system, we all acknowledge, is largely designed to mass-produce, highly processed, shelf-stable food, including products that are especially diabetogenic. This is not necessarily by design. This is a consequence of the desire to feed the billions of people on the planet. But when many of the policies were developed that led to the contemporary food system, type 2 diabetes was a relatively rare disease. Next, most behavioral settings, workplaces, recreational settings, etc., serve highly processed foods, often exclusively, with no other choices. Next, income inequality and food insecurity lead to disproportionate levels of consumption of diabetogenic foods among vulnerable populations and very low levels of consumption of nuts, fresh fruits and vegetables, and other healthy patterns of eating. Finally, nutrition research has been disjointed, has not had a clear agenda or public health voice, has largely suffered from significant conflicts of interest and industry manipulation as they have been the primary funders of this research, and generally has focused on specific nutrients rather than what we do as humans, which is eat food. So food-based dietary patterns have been understudied. So again, for discussion by the NCCC here to consider, we believe that we need to move forward broadly on 3 bullet points. No, it's actually 4. Advanced health communications. Food or beverages, product or advertisement labeling interventions or policies should be considered, such as pictorial icons that are easy to understand, improved communications around nutritional quality and content, caloric content, warnings, communication campaigns, and even regulating advertisements that target children and youth. In addition, we should be considering economic or setting-based incentive or disincentive interventions or policies that affect a number of programs such as SNAP, WIC, school programs, fresh fruits and vegetable vouchers, food delivery, restrictions on sales in certain settings, excise taxes on distributors, etc. Third, we really need to better engage the private sector and innovate around agricultural policies to adapt and change our food systems through investment and innovation. And I believe now is a time when food and beverage companies are more than ever thirsty and open for this kind of change. Fourth, we need to encourage systematic policy and implementation research, including natural experiment evaluations, simulation, and well-designed trials to answer important questions in nutrition science. I say this because it is nearly impossible to do randomized controlled trials with 40,000 people and follow them for 10 years and have half of them be exposed to sugar-sweetened beverages and the other half to not be exposed. It's just unethical and infeasible. There are a number of natural experiments going on that relate to food systems and food policy that need to be harnessed if appropriate funding were available. This kind of research really needs to be coordinated in a collaborative fashion, not just within, but between NIH, FDA, USDA, FTC, and CDC, each of which themselves has tremendous research expertise, but together, we know from some case studies, can really amplify the effects. And that this research needs to be entirely free from industry influence and financial conflicts of interest. We currently, as a subcommittee, are reviewing and developing a variety of specific recommendations related to these 4 bullet points, but I wanted to raise them here today for discussion, these domains. Quickly, and then I will wrap up. Moving forward, we are now awaiting the first round of a comprehensive literature review that relates to the domains of diet and nutrition. And I just want to point out in red a few things that we are highlighting. Any dietary intervention or policy associated with incident disease, anything in that of those interventions that are associated with changes in consumption of what we know to be foods and beverages that promote diabetes, or conditions that promote diabetes, such as food insecurity and health disparities. And then lastly, cost effectiveness of studies of such interventions. Similarly, we are doing a targeted set of literature searches around health communications related to beverage and food products or advertisements, including labeling interventions, etc., as well as a deep dive search around incentive and disincentive interventions or policies that have been studied with respect to the outcomes described above. So this is underway, and we hope within the next 4 to 6 weeks to have those results that we can begin to cull. The next steps that we're going to engage in are additional key informant presentations. They are listed here. And finally, this is actually slide 3 of the next step. We plan to conduct additional interviews, as Ann Bullock mentioned, with key agency contacts across specific health and non-health agencies, USDA, FDA, CDC, HUD, NIH, Administration for Children and Family, etc., to gain additional information beyond the federal data call. We're going to expand the literature search gradually to include the other domains listed in the diabetes care model, transportation, housing, etc. And then we will need to synthesize these literature searches in a sequential manner. We will then refine our current work to draft specific recommendations related to health impact assessments and the nutritional domains just described, and then move forward to develop focus areas for domains related to the other drivers of type 2 diabetes and disparities, such as physical activity, stress, poverty, etc., that Anne mentioned when describing the diabetes care model. And finally, and most importantly, we need to begin to engage together in crosstalk and sharing regarding the overlap and synergy with other NCCC subcommittees. By way of example, interventions at the population level to prevent diabetes, as I'm sure you will appreciate, can also have tremendous impact on preventing diabetes in targeted populations and preventing diabetes complications in those who already have the disease. So while our subcommittee is called prevention, the work that we are doing as a subcommittee will have a tremendous collateral benefits to the work of the other subcommittees as well. I'll pass it back now to Anne to close with a framing, and then we can open up to discussion.
Thank you, Dean. And just quickly, acknowledging the situation that we are all in now with COVID-19, and including with that, that diabetes is a huge risk factor for severe COVID-19 disease and mortality, unfortunately, as well. In looking at COVID-19, we realize that it's so connected to what's happening with diabetes, and the current issue of JAMA has a really wonderful editorial talking about COVID-19 and health equity, and we thought it was a good way to kind of frame and close our discussion today. So COVID-19 disparities are not the fault of those who are experiencing them, but rather reflect social policies and systems that create health disparities in good times and inflate them in a crisis. The U.S. must develop a new kind of herd immunity whereby resistance to the spread of poor health in the population occurs when a sufficiently high proportion of individuals across all racial, ethnic, and social class groups are protected from and thus immune to negative social determinants. So we know, again, that diabetes is a risk factor for COVID-19 severe disease. We also know that we are all looking for herd immunity, whereby preferably through vaccination, as opposed to exposure, but that a certain amount of immunity will occur in the population so that the issue of COVID-19 transmission becomes a non-issue. So thinking about herd immunity, though, it's not just immunity to that virus, and of course Williams and Cooper are pointing out that we need to look at the underlying issues that are creating these disparities in COVID-19 outcomes, and to help people to deal with these negative social determinants, and in that sense become immune and so to speak, increase herd immunity. But I want to challenge us all to replace the word at the beginning of this, which is COVID-19, and put in its place type 2 diabetes. If we said type 2 diabetes disparities are not the fault of those who are experiencing them, but rather reflect social policies and systems that create health disparities in good times and inflate them in a crisis, I think we would have a very accurate picture of what we are seeing here. COVID-19 is the acute outcome related to so many of these social determinants, whereas type 2 diabetes through this lens of the socio-ecological model can absolutely be seen as the outcome of these disparities in social determinants, in stress, and in so many other things that affect people at particular risk for developing diabetes and its complications. So with that, we'll thank you and open it up to discussion. Thank you.
Good. Thank you very much, Anne and Dean. I also want to thank the individuals who submitted public comments for the Commission, and I think they'll be pleased actually how well this subcommittee has begun to address many of the issues that they raised in their comments. So I think Anne and Dean have done a nice job in highlighting some of the issues, summarizing some of the gaps in the information that we've received from both the health-focused and non-health federal agencies, and really highlighted the rationale for health impact assessments and initiatives in the area of diet and food policy. I think that the next steps they've outlined are very reasonable, and I think this analogy to COVID-19 and type 2 diabetes with respect to health disparities is very cogent. I'd like to open it up now to other members of the Commission for questions, clarifications, and comments with respect to what's been laid out by the Prevention General Population Subcommittee. Any comments or questions from the members?
Hi, this is Sherry. Thank you guys for presenting that, and I think that was a great summary and discussion of what's going on in the subcommittee. I like the idea of health in all policies for the federal agencies. I'm not sure how I feel about health impact assessments. I've actually never heard of that term before, so this is new to me. And I guess I don't have a good sense of how that may be restrictive or not to a particular agency, and it also wasn't clear to me fully how, not being familiar with them, I think there was some data presented on perceptions of improvements, and I'm not sure how many have actually shown actual health improvements, and I don't know how extensive or challenging it is to conduct those. So, so I just throw that out there. I don't know if you have any thoughts on a practical level. Sometimes when you put in sort of regulations around, a health impact assessment sounds good, but what does that really look like, and is that restrictive in any way, and should we be thinking about, what that looks like? So that's all.
Dean, do you want to take that?
Sure. Yeah, thank you, Sherry. A multi-part question. So health impact assessments are like many things in health, a very complicated field with a lot of literature and a lot of expertise and experience to go with it. It would be difficult for me to summarize that, and I'm by no means an expert. However, the website that I included, the Pew Charitable Trust website, is the repository for the answers to the questions that you just raised. In addition, the National Academy of Medicine report, as well as the CDC resource listed, also address some of these issues. I will say that there is no question that having a process that requires a health impact assessment would and could be seen as restrictive and bureaucratic because it means that there is a temporary brake placed on a policy at some point in the process, hopefully the earlier the better, that would force non-health sector agencies to ask the question, what is the impact of this new policy that is either sunsetting, we're going to renew, or we're trying to roll out? What impact might this have on population health and specifically around diabetes? Right now, as we learned from many of the presenters, with rare exceptions, that question is not asked. The issue of how efficiently, quickly, and responsively a health impact assessment can be performed is entirely dependent on the expertise and resources put behind it, and the priority that timeliness is prioritized. Let's put it that way. I will say, however, there has never, to my knowledge, been a randomized controlled trial of 10 programs that were subject to a health impact assessment and 10 similar programs that were not subject to a health impact assessment. Although I do want to defer to Ann Albright if she knows anything different in that regard. So while a number of very important public bodies, including the CDC, including the Institute of Medicine, Robert Wood Johnson, a number of entities have essentially recommended that HIAs be implemented across local and state health departments because of their face validity and the pre-post results that have been observed. I'm not familiar with any very rigorous studies to assess that. But a little bit of this would rely on our ability to think of this as having face validity.
Ann Albright. Ann, did you have any comments to Dean's question?
No, Dean's right. This is certainly something that parts of CDC have certainly recommended as an important tool for state and local entities to use, but we don't have trial or research data as has been described.
And Sherry, you endorsed the idea of health in all policies. How would you see that as differing from the formal health impact assessment that Dean has outlined?
Yeah, I guess I just wondered if there was any breadth in what we recommend as, and what how long and how sort of nimble the HIA sort of pieces, having not done one. I mean, we do a lot of community health improvement plans and things like that, both within the health systems as well as the public health agencies. And but this sounded different than that. And I think, I just don't know what the potential, negative consequences of putting into place something that I have no idea how long it takes. So I guess it was just a question of, maybe there's more than one approach to having health in all policies besides just a health impact assessment, and we might want to consider if there's, any breadth to that. And again, not knowing a lot about how HIAs are completed, maybe there is variation in how extensive or how, what sort of range that is in terms of complexity to complete. So that was just a sort of a comment.
And Bill, I just wanted to add one issue.
Go ahead.
What has been observed in other countries that have adopted health in all policies in their decision making at the federal level is that over time, I think as we saw from some of the results of the research I presented, that the health impact assessment process itself begins to change the mindsets of those in the non-health sectors to begin to think about health even before a health impact assessment is done. By way of example, Singapore is now doing a national diabetes prevention program, and the sectors at the table are almost exclusively non-health sectors. And that's not because of any health impact assessment going on right now, but because of a tradition of doing health impact assessments that then they realize, we need transportation, we need agriculture, we need it all at the table. So there is a bit of there is a tool and a bureaucratic aspect to this, but there's also kind of a way of thinking about policymaking that may emerge.
I was just going to say, I think a formal health impact assessment would have time and resource implications, and from the discussion,
Definitely.
I think it would be worth exploring other potentially less resource-intensive options in terms of getting all relevant parties to the table and putting health on the map in terms of new policy initiatives.
I agree, and that's partly what the bullet point around deciding the conditions on which a health impact assessment would be required, I would add, and defining a framework for, health impact assessments, because there are many levels of precision and thoroughness with which they can be done.
Good. Other comments from Commission members on the health in all policies framework? And if not, why don't we think a little bit about diet and food policy and some of the next steps there? Are there comments on that?
Yeah, sorry, this is Sherry. The only other thing I'll bring up as we talk about, is there other models? I mean, I don't know. I mean, just thinking about the collective impact model is another way to think about bringing diverse stakeholders to address sort of a social problem. So that I just throw that out there for thought. It's just off the top of my head. And Dean, you may know about that as well. It's not a formal assessment, but it's also another way to think about bringing diverse stakeholders together
Yes.
to address something.
Agreed.
Barry, do you want to say a few words more about that for folks who aren't familiar with that?
Sure. So a collective impact model, and I can send a link around to the group about it, but it's just a phased process of bringing really diverse stakeholders. It's been used in education a bit more than health, but it has been used in health improvement collaboratives as well, where you just bring a wide range of folks to the table and do strategic planning around a particular challenge. So if it's been used around education, if there's educational challenges, we've used it here to look at health improvement and where do we want to focus as a community. So it's just there's sort of 5 phases and I think four or 5 elements, but it's really just a way to bring people together. You do strategic planning, you talk about shared measurement, and you sort of align organizations and community groups that are already working on health to just really align a lot of the community efforts together to address significant challenges. So that's a high level, and others may have experience with it and want to add to that, but that's really strategic planning, sort of shared vision and mission, aligning efforts, and having shared measurement.
Yeah, this is Ann Albright. Interestingly, when we embarked upon developing the National Diabetes Prevention Program, it turns out, excuse me, that we were actually using a collective impact model to do that. So it is a very effective model, one that's, as Sherry mentioned, for education, but considered for social change. And I think that's obviously what we're trying to do in many regards here. So, yeah, the common measures are critical, the common agenda, reinforcing activities, which allows you to work across a continuum. So in this case, it would allow us to do sort of starting from in utero all the way across the life stages. It also allows us to work across the whole population approach to the targeted population approach, and then certainly those things that impact people with diabetes. So it's an interesting and useful framing to use, but people do have to get it and embrace it. It requires reinforcing communication as well, and I think sometimes that's where we can falter a bit because what we're trying to tackle is large, it's complex, and it does mean that people don't sort of grow faint of heart, that they stick with things, that they continue to adjust as you move forward. But it is a very interesting model, helps you frame really important factors. And, you know, you combine it with things like Dean and Ann pointed out with the sort of again, the socioecologic model and some of these other things that could be very, very helpful.
Yeah, I will just comment. I agree. My experience with the collective impact model has, and how it differs from the health impact assessment tool, is that in general, when people come together around a collective health model, they have a general shared vision on an outcome related to health. Let's reduce gun violence. So there is a starting point of general uniformity, and then it's around how can we get there. I think what we're trying to put forward here, while the collective health impact process is outstanding, is that by and large non-health sectors are certainly not charged with, nor are they necessarily thinking about the health implications of their policies and practices. And so in order to engage in a collective impact process, one needs first to ensure that the non-health sector recognizes health as an important part of its mission.
Good. Thank you, Dean. We only have a few minutes left. I wanted to see if anyone had comments about the initiatives related to diet and food policy as well. Any thoughts on that?
This is Ann Albright again. I guess I would just say I look forward to the conversation that you'll have with CDC There is a lot of work going on in that area. You certainly mentioned NOPRIN and other efforts. There's been a lot of coalescing of groups together around food-related issues, and I think that'll be a really rich discussion.
Totally agree.
Good. And any other comments about future directions or anything else that was brought up by Anne or Dean?
Can you lower them?
Good. Well, I think we're right on schedule. Thank you very much for that presentation. I think the next presentation now is focused on prevention targeted population, and Ann Albright and John Boltrey will be leading that discussion.
Thank you, Bill. Can you hear me?
Yes.
Okay, this is John Boltrey. We're going to review our framing statement and then review our focus areas, talk about how we have organized our work, then review what we have learned from the federal agency data calls and the external stakeholder calls. Time permitting, we'll talk about our literature search questions and then end with next steps and future directions for our committee. So, next slide. So, in the United States, more than 1 out of 3 adults have prediabetes. Individuals at high risk for transition to prediabetes and type 2 diabetes include those people with obesity, low physical activity levels, a family history of diabetes, those that come from high-risk racial and ethnic populations, and women with a history of gestational diabetes. Effective preventive interventions such as certain structured lifestyle change programs and medications will markedly reduce the progression of prediabetes and have been shown to be cost savings and cost effective. To promote better uptake of effective interventions, the at-risk population needs to be identified, provided with increased understanding of risk factors, improved access to proven prevention strategies, and tools for positive behavior change. Healthcare providers also need strategies to increase their uptake of prediabetes screening and tools to increase awareness and implementation of proven prevention strategies. Both those at risk and clinicians need support for increasing awareness, accessibility, and affordability of screening and prevention for type 2 diabetes. Additional research is needed to develop improved strategies for promotion of and adherence to positive behavior change to prevent type 2 diabetes, especially over the long term. Research is also needed to develop interventions to prevent development or slow progression of type 1 diabetes. And of note is that 90% of people that have diabetes are unaware, that have prediabetes are unaware that they have prediabetes. Can we have the next slide, please? So we have 4 main focus areas for our subcommittee. The first is screening. Many people, as a matter of fact, most people who have prediabetes do not know they have prediabetes. Either they have not been tested or have been tested positive and do not know they have prediabetes. We want everybody who has prediabetes to know that they have prediabetes. Ideally, everyone with prediabetes would participate in and complete one of the diabetes prevention programs that has been specifically scientifically proven to lead to delay or prevention of type 2 diabetes. We seek to increase the number of people with prediabetes who participate in and complete a diabetes prevention program. Next slide, please. While some people with prediabetes who successfully complete a diabetes prevention program are able to maintain the gains they achieve in diabetes prevention, many people are not able to maintain the gains they achieve in weight loss and exercise, and ultimately lowered A1C. We need programs, and we need to find programs and develop programs that help people maintain long-term the reduced risk of developing diabetes by continuing the gains that they achieve in a diabetes prevention program. While we have proven ways to delay or prevent type 2 diabetes and its complications, such as the National Diabetes Prevention Program and certain medications, we need to continue to explore different and possibly better methods and new medication treatments for the prevention of both type 1 and type 2 diabetes. It is important to continue to fund development of more effective methods and medications for preventing diabetes, including individual and population level strategies. Now I would like to introduce Ann Albright, who will discuss how we have organized the work of the Prevention Targeted Population Subcommittee. Ann?
Great, thanks, John. And I'll just do a quick sound check, make sure folks can hear me, and also just ask folks to mute. We're hearing a bit of shuffling around, so it would be great if everybody checks the mute button. Our group deliverables, I'm just going to walk through how we've approached this, and then as each group shares what they have been working on, I'll ask the person who's stepped forward to be lead of that group to introduce the members of their group. This is a terrific group to be working with, and everybody has been working very, very hard. What we had decided to do as a subcommittee was that we would divide ourselves into sort of work groups. And what I'm sharing with you on this screen, and I'll go through the next couple, is to just give you a sense of what each is working on. Group 1 has been working on summarizing the federal agency data call reviews. Again, a huge task. We got certainly a lot of information from many of the agencies. And as been noted by our colleagues in the previous discussion, that there are still certainly remaining questions, things that we still want to know more about, and are continuing to process those data. But you'll hear in a moment from Group 1 who will describe what they have been doing and the summaries that they have provided. Group 2 has taken on the task of summarizing the stakeholder informant calls and their comments. And so you'll hear in a moment as well from that group, and they'll identify the stakeholders we've spoken to and the kinds of information and recommendations that we have gotten from them. Group 3's charge is to identify gaps where more information and data is needed, and to get and obtain that information which is needed to complete our work. And that group is just getting underway, so you'll hear from them and sort of the approach that they're taking, because certainly we're looking at getting information and looking at gaps in what we got from the federal agencies, those summaries, but also what else we need to do as a subcommittee. What are other topic areas that fall under targeted population that we must be working on? And so they will be doing additional queries and either written or phone calls with federal agencies to determine those gaps and then synthesize that information for us as well. Move to the next slide. Group 4 is working on our literature search, looking at the search terms, trying to, again, ultimately summarize the results from that final report. I just want to make a note, this is not an easy area because there's so many questions that we could be tackling, so many areas that one could be working on, and we just want to make sure that what we are indeed searching is most focused and targeted on what we are charged to do in this subcommittee. And finally, the initial draft of our recommendations. We have already begun to gather some draft recommendations, but it'll be the entire subcommittee that will work on these as a group, and we will get those again drafted and look to see where we may have additional gaps that need to be filled before we have our final recommendations. Next slide, please. I'm going to turn it now over to our Group 1, and Naomi will be starting us off, and then no doubt turning it over to some of her subcommittee members. So Naomi, thank you for introducing the folks on your subcommittee, and we'll hear about what we have accomplished under the federal agency data call. Thanks.
Great. Thank you very much, Ann. And the other group members included Barry Marks and Donald Schell. And we reviewed the data call results from the 11 federal agencies that you've heard from described earlier in Dean and Ann's presentation. And from the standpoint of the data that we reviewed, we are focusing on those programs that we felt would be most impactful for the targeted population subgroup for the NCCC. So the first would be the Center for Disease Control, or the CDC, where there are 6 programs that were identified primarily, and the biggest one would be the National Diabetes Prevention Program, or National DPP, which includes the Diabetes Prevention Recognition Program, a Customer Service Center, National Operations Center, and a Program Locator. In addition, there are 5 cooperative agreements with the CDC and state local health departments, national organizations, tribes, and U.S. territories and island jurisdictions, in addition to multiple other projects that have expanded access to and health benefit coverage for the National DPP. And this has increased provider referrals, and with a major emphasis on reaching and retaining vulnerable populations. In addition, the CDC has interoperability standards for supporting electronic referrals to the National DPP, has been involved with behavioral, economic, and applied research on type 2 diabetes prevention, as well as prediabetes risk factor surveillance program and national prediabetes awareness campaigns. And if Barry is connected, he will discuss CMS.
Thank you very much. Hopefully you all can hear me.
Yes.
Okay, thank you. For CMS, there were 4 areas of CMS programmatic activity that were highlighted from the data that was received by the Commission. The first is the Medicare Diabetes Prevention Program Expanded Model Demonstration. The second is the Diabetes Self-Management Training Benefit. The third is coverage of technology and therapeutics more broadly. And finally, the medical nutrition therapy benefit under Medicare. Now, Naomi, do you want me to go ahead and talk about the VA programs?
Sure. Or was that Don?
No, actually, we reviewed VA.
Okay.
This is Ann. Maybe for ease of just slide progression, we just go in the order they're in, and then we can advance the slides accordingly. That may be a bit easier.
Right. The next one is the VA. So, Don.
No, we actually, I did that.
Oh, you did the VA?
Yes.
Sorry.
Yes.
Okay.
Go ahead, Barry.
Yeah, thank you. So there were 4 VA programs that were highlighted from the material submitted. The first is MOVE, a weight management program for veterans. The second is the Telephone Lifestyle Coaching Program. Third is lifestyle training to promote healthy eating, the prediabetes group classes. And finally, the glycemic safety in the inpatient hospital setting initiative. Over.
Okay, and on the next slide, that's where we'll start with Don, who had reviewed the Department of Defense.
Okay, good afternoon all. So from the Department of Defense, there are many different initiatives that have been utilized for targeted populations and for our service members and our beneficiaries. We have our group lifestyle program. We also have which is a transition from intensive to individual to diabetes primary prevention program. We also have services for our retired service members. The department's also involved in research, education, food nutrition assistance, diabetes prevention, and the treatment programs, and a number of different activities and initiatives for all of our beneficiaries. The next one that I reviewed for our subworking group, is the Office of Minority Health. They have partnerships for about 15 different policies and programs that are sponsored by 3 different primary areas that are focused on multiple different minority targeted populations, which are those Empowered Communities for a Healthier Nation grant, the State Partnership Initiative to address disparities, and also the Partnership to Achieve Health Equity, the PAHE grants. And so number of initiatives in both those 2 agencies that are focused on reaching those targeted populations for prevention, and there are a multiplicity of them. Back to you, Lily.
Thank you. So for the Health Resources and Services Administration, or HRSA, 2 programs were identified with a small focus on targeted populations, and this included specifically obesity and diabetes, and with the plan to add prediabetes to their initiatives that relate to rural health care services outreach and the Delta program. For the Indian Health Service, 3 opportunities were identified, and that would be a program entitled the Special Diabetes Program for Indians, which includes statistical reduction in prevalence amongst AI and AN populations. Secondly, community health representatives, and thirdly, a program in community health aid program. In the Bureau of Prisons, they are an excellent example of how one agency borrows and adapts the products of another agency, in that they've adopted for the Bureau of Prisons CDC materials from the National Diabetes Prevention Program as part of their initiatives. On the next slide, we have summarized, the next slide please. Summarize the 3 agencies that largely focus on research, which starting with the National Institutes of Health, which funds observational and interventional research related to targeted prevention of all types of diabetes and in all populations across the lifespan. And these projects may be aimed at identifying, understanding, and targeting the biological, social, psychological, behavioral, nutritional, genomic, autoimmune, and environmental variables that put individuals at risk for diabetes. And the research ranges from basic clinical all through translational research, as well as having data and specimen repositories and small business innovation research programs and grants. And as many of you are aware, NIH supports training and career development programs where the grantees conduct supervised research relevant to the prevention of diabetes. So that's a very large program that provides information that we can use in terms of the implementation in our various individual agencies. The USDA itself had no specific program for the prevention of diabetes in targeted populations, but as we all know from the standpoint of food and nutrition programs, as well as their research projects supported through the National Institute of Food and Agriculture, or NIFA, these may all be applicable to diabetes prevention in targeted populations. And finally, the Agency for Healthcare Research and Quality. Again, no specific programs were identified for the targeted population, but we do know that their extramural U.S. Preventive Services Task Force and their intramural annual National Healthcare Quality and Disparities Report are relevant to targeted populations. Happy to entertain any questions.
Yeah, I think we'll do those in our Q&A period. So thank you
okay.
so much. Really
thank you.
Appreciate that. We're now going to turn it over to on the line. Shannon, are you on the line? Or Susan, on the line now?
Yes.
Great. We'll turn it over to you. Shannon, your partner in this subgroup. So,
thank you.
A summary of our stakeholder calls.
Shannon Idzik and I were responsible for summarizing information and key points from the calls with 4 stakeholder organizations. And so I'll be reviewing those and then at the end concluding with some observations and recommendations that seem to be most common across these 4 calls. The first stakeholder organization that we've got on the slide here, National Association of Chronic Disease Directors. They have 3 categories of conclusions and recommendations. The first one is to improve public health surveillance, and that would involve increasing resources for screening, and they emphasize especially in underserved populations, and then to have both timely and actionable data on prediabetes, both prevalence of prediabetes and referrals to programs, and that's in the spirit of guiding allocation of resources within the states that are served by these chronic disease directors. A second category is to increase access to curricula of the National Diabetes Prevention Program, the National DPP, and they propose doing this by coordinating support from other agencies with CDC for expanding access to the National DPP. They would also recommend providing local organizations with administrative support for delivery of the program. And this would be for instances where those local organizations actually have the expertise for delivery, but their needs are more for management infrastructure rather than program delivery. Access might also be increased by accumulating data, particularly costs, for policy changes by commercial payers. And again, with these data, they may be able to make arguments for creating or increasing coverage for the national DPP. Other policy changes that were suggested by the chronic disease directors included maximizing resources from Medicaid and Medicare, and specifically for the changes in Medicaid they were referring to were for those states that have been, let's say, less ambitious in establishing the national DPP within the state, and for Medicare, as I note here, the A1C screening, that changing coverage for policies regarding A1C screening to enhance identification of persons with prediabetes. And the final category of recommendations from chronic disease directors is to allocate funds to improve social determinants of health, and some specific mentions were food and activity environments to make them more conducive to healthy behavior, and then both transportation, support for transportation, as well as high-speed internet access, and these sort of are somewhat parallel in terms of improving access to prevention resources, either via in-person resources with better transportation and support for that, or through broadband and high-speed internet access for remote access to prevention resources. Next slide. So our next stakeholder call was with the American Academy of Family Physicians. They also emphasized social determinants of health. They suggested that the importance of adequate income is not just for what you can afford, but also for what you have the time and energy to do, and how that might relate to engaging in prevention programs, and also for where you can afford to live and the degree to which that affects your access to affordable and accessible healthy foods and a safe activity environment. They also stressed the importance of coverage in all states by Medicare and Medicaid for screening and prevention programs, and the gaps that they noted included, as I had mentioned in the previous slide, Medicaid support for the national DPP, in all states. And with regard to Medicare, some of the clinical services that are related to screening and prevention. And the final bullet here was support for embedded behavioral health coaches in primary care practices for long-term support. And the idea here was that even where there is access to the national DPP, that there may be need for post-program services to support behavior change in the patients that they see. And this might be accomplished either by adding staff with expertise in behavioral change, or by training existing staff to provide that resource. Next slide. So our third stakeholder call was with the American Association of Nurse Practitioners. They stressed increased access to the national DPP, and they thought that that would be particularly helpful by expanding virtual delivery of the program. And this was not only motivated by response to COVID-related pressures, but also for making the program available in more places and at more times of day and days of the week than it can be made available if you're relying on the in-person mode of delivery. Second category of recommendations was to address reimbursement barriers, and in particular, they advocated for allowing Medicare coverage for nurse practitioner-ordered medical nutrition therapy, and this involved not only who would be making that order, but also beyond that, coverage of medical nutrition therapy for prediabetes within Medicare. And then, a second reimbursement issue was to expand services of certified nurse diabetes educators specifically for patients with prediabetes. The Association of Nurse Practitioners also spoke to the importance of social determinants of health. They specifically mentioned transportation and did that sort of in connection with the virtual delivery of the national DPP as a strategy to compensate, at least in the short term, for transportation as a barrier to access to the program. And a final bullet there, increased relationship between the association and federal agencies, and a specific point made there was to support nurse practitioner education so as to improve the workforce, expand the workforce for prevention of diabetes in the targeted population. Next slide. So our fourth and final stakeholder organization is the American Medical Association. Their first category is also increased access to, and I should say access to and participation in the national DPP, that they would accomplish this through increased screening and referral so as to enroll more people with diabetes in the national DPP. And by increasing demand for the program, they would also respond by increasing supply via employing virtual delivery of the national DPP. This third bullet, eliminating one-time benefit provision, is a little cryptic in terms of our transcript and notes from the call, and we'd need to contact them for clarification, and it could be that that was reference to restrictions on re-enrollment for the national DPP if in fact there are individuals who could not complete it or feel they may benefit from a second tenure in that program. The remaining recommendations from the AMA include coverage for A1C testing to screen patients for diabetes under Medicare Part B, and again, as a potentially preferred alternative to fasting glucose. Also adopting a set of quality measures related to prediabetes, and last but not least, increasing coverage for medical nutrition therapy and metformin in patients with prediabetes. And I mentioned before with medical nutrition therapy, the concern was Medicare not covering this for prediabetes. Also, this last bullet was suggested to be especially important in places or for persons who do not have access to a local program for the national DPP. So next slide. So you may have already gotten a sense for this that we had and heard multiple times from these separate conversations with stakeholders, several recommendations for federal government. First, to address social determinants of health, understanding that some may be logistically and politically more feasible than others, but could not be denied in terms of their relevance for the targeted population who had increased risk for diabetes. There was also a pretty consistent and common emphasis on increasing screening for diabetes, and two key points there were particularly for medically underserved populations, and then also with greater ability to use A1Cs for this purpose. And that's also mentioned under these final two bullets or categories for different kinds of barriers. Beyond A1C and its implications for screening, there was also a consistent advocacy for more support for prevention, particularly expanding access to the national DPP with virtual delivery as a very popular and leading strategy, and then also access for other kinds of prevention resources where there may be different kinds of barriers, either in access or policy and coverage, and that included the behavior therapists, the registered dietitian and nutritionist, and finally a certified diabetes educator. So that is my summary of these 4 calls and separate recommendations as well as the ones that we were heard most frequently.
Thank you, David. Let's move on to the next slide and ask Howard Tracer to lead us on this discussion.
Thank you, Bill. It's Howard Tracer here. And first, I want to start out by acknowledging the other members of my group, and those are Barbara Lindner, Ellen Leak, and Samuel Wu. And our group is looking at what are the gaps in our subcommittee's knowledge about preventing diabetes in targeted populations. We're going to start out as next steps over the next several weeks by looking at the summaries of the data calls and diving back into the federal agency data calls themselves and asking what additional data or knowledge do we need from those agencies to sort of inform our work about what the agencies are doing related to diabetes prevention. And that's where we're going to start, and that's our concrete next step. And as we do that, we're going to do that through the lens of the subcommittee's focus areas, which you've heard about before, and those are improving screening and diagnosis for prediabetes. How do we improve access to and utilization of effective methods to prevent progression to type 2 diabetes in persons with prediabetes? How do we improve the sustainability of type 2 diabetes prevention? And that's both at the individual level and the programmatic level. And finally, research into new and more effective diabetes prevention strategies. So we have very good strategies, for example, that you've heard about with the DPP, but it would be good to see what agencies are doing to develop new and perhaps more effective diabetes prevention strategies. As we do this more concrete work, we don't want to lose sight, and this is really the whole subcommittee's work, but we also want to keep our focus on important knowledge gaps at broader levels that we also need to address. For example, two on the slide, we need to look at overarching or cross-agency gaps in diabetes activity. For example, how are diabetes activities coordinated across agencies? And obviously no one agency will be able to answer that question, but that's an important question for our subcommittee and the commission to address. And then also, and we'll hear about that a little bit more in the future, we'll hear about that a little bit more from Ann and John, but just in general, our gaps in knowledge about diabetes prevention. Again, we've talked about diabetes prevention program a lot, and that's a proven way to decrease the risk of progression to diabetes. But what's the role of medication diabetes prevention? What's in different medications? What's the role of bariatric surgery in preventing diabetes? And we certainly need improved strategies to prevent type 1 diabetes. So that's the high-level overview of where our group is at now.
Thank you, Howard. Can we have the next slide, please? And we're right on time. So I want to talk a little bit about our research, search questions for our literature search. And some of the same themes that Howard just talked about are going to emerge here. So really, we seek to identify the literature that is relevant to our focus areas. In order to develop policies and programs that increase the screening rates for prediabetes and increase the uptake and completion of diabetes prevention programs, we need to establish some goals for screening and uptake. To establish those goals, it would be helpful to know the current rates of screening and uptake of DPPs nationally and regionally. It would also be helpful to understand the comparative effectiveness of the various diabetes prevention programs that are currently available in real-life settings. For example, we know that people with prediabetes who participate in programs with a greater number of sessions tend to do better than those who participate in shorter programs. What we want to know is what is our current knowledge of studies looking at the barriers to participating in programs with a greater number of sessions and how to overcome those barriers. For example, in rural Ohio, where our medical school is located, it can be a 40-minute drive to go to a diabetes prevention program. If you're living there with limited transportation, it might be hard to participate in weekly sessions of diabetes prevention programs that go on for 4 or 5 months. Also, what are successful ways to get people to participate in and complete diabetes prevention programs? Do incentives help? And we'd like to know what is the impact of social determinants of health on completion of diabetes prevention programs. Next slide, please. Concerning medications, what is the current state of medications for the prevention of type 2 diabetes? What is the current knowledge of the relative effectiveness of medications for the prevention of type 2 diabetes? And finally, what is known about maintaining successes achieved in diabetes prevention programs? What are the best practices for helping people maintain weight loss and exercise achieved? We all know that it's hard to maintain weight. When you've lost weight, it's hard to keep that off, and also it's hard to maintain behavior change. So what do we currently know about that? Are there studies out there that tell us, that might inform us on the recommendations that we've been talking about for the last 40 minutes or so? And I'll introduce Ann Albright again, and if you can pull up the next slide, please. Ann, are you there?
Can people hear me?
Yeah. Yes. Anna, try it again. You were breaking up.
Okay, let me try to change places. How's that?
That's good.
Better.
We're going to, our next step with our small group are, as we've indicated before, it's to summarize the federal agency data call reviews, so we're going to be getting those ready for the final report. Same with our stakeholder informant calls and their comments. What we heard about in identifying the gaps, then more data is needed from the federal agencies, and then those additional inquiries that we will need to make. And then you heard just recently heard from John about the literature search and the kinds of questions we're going to be asking. And then, of course, we'll be digging into getting our initial recommendations written for the final report. So we've got certainly these next steps for our small groups. But if you'll move to the last slide, future directions, we, as you've heard mentioned throughout the presentation, medication for prevention of type 2 diabetes or medications, we have not yet tackled that, and we need to begin to work on that. Same with surgical interventions for type 2 diabetes. And then, very importantly, areas of research for prevention of type 1 and for improving type 2 diabetes prevention. So we really need to tackle those areas as a subgroup as we have our small group work completing what they're working on right now. And that's it.
Great. Thank you very much, Ann and John and team. I think we're right on time. This is Bill Herman. I did want to start with a couple of questions. First, I think the issue of prediabetes case finding and referral is really critical. And it seems that there are a number of separate issues. First is undiagnosed prediabetes, but we also know that there are a lot of people with diagnosed prediabetes who are unaware of their diagnosis. And part of that may reflect the interaction between providers and patients. The other issue is a lack of provider referral. There have been some older studies that suggest that only about 25% of primary care physicians have ever referred to a diabetes prevention program. So I'd like your thoughts on perhaps drilling down more on the issue of case finding and referral. And just quickly, the second point relates to hybrid approaches. I don't necessarily see it as either lifestyle interventions or pharmacotherapy. What about hybrid approaches for weight loss maintenance with both? John or Ann?
Yeah. I think you raise really critical questions. I think those may be things to add to our literature search and see what's available in the literature. They may also be questions we want to take back to the federal agencies, because I can certainly say CDC has been working in some of these areas, particularly around referral. Our partnership with the American Medical Association, they are very dedicated to doing that. So I think both may be asking those questions specifically of federal agencies, and then looking to add how we would frame those questions for the literature review.
Bill, can I ask a question? This is Dean.
Sure.
Thank you, guys. This is an awesome presentation. So here's my question. Obviously, what we're talking about with the National DPP is of a massive scale and with a relatively intensive intervention. And as you're well aware, the diagnostic testing criteria to determine whether someone has prediabetes are a subject of pretty intense debate, with certain tests having certain specificities and test characteristics and other tests having greater sensitivity, less specificity, etc. I think it's fair to say that we don't, as my understanding, we don't have the great test that really is feasible and easy to administer, and that distinguishes those who've got an elevated glucose who are likely to go on to develop type 2 diabetes within a certain period of time from those who've got an elevated blood sugar, but really their likelihood of progressing to type 2 diabetes is relatively unlikely. And so I'm wondering whether some of your future work or future questions could include advancing a research agenda. Then this may be basic science work, I don't know, or immunoassays, or who knows, but on gaining a better understanding of those markers of prediabetes that would help us identify the subset, which may be significant but won't be as large as the current prediabetes population, for whom the DPP intervention would be maximally effective. Because right now, if we do the hemoglobin A1C test, we're talking about massive amounts of people, and the predictive value of the hemoglobin A1C with respect to progression is not great, as you know.
Yeah, thanks, Dean. It's a great issue. It's a great question. I think we could certainly and should add it to our potential areas of future research, and you're right, potential areas of literature examination. In the real world of delivering the national DPP, there are certainly why we allow all three methods in addition to a risk test score. But yes, it's always best to be able to deliver any intervention, whether it's medical, lifestyle, whatever sort of intervention that's best suited for the person. Until we get there, we need to continue to, press forward and hopefully use some of what we're finding as we identify people for the program that may allow us to set up some of those kinds of research studies. There is also,
that seems like a great opportunity, right? Yeah.
Yeah. Well, and as folks I'm sure are aware too, there's obviously a debate as well around the cutoff for particularly the fasting glucose, whether it's 100 or 110 lower bound. And I think it's time to re-examine that literature. We have raised that issue with the American Diabetes Association. Hopefully we will be able to proceed there. But I think, yes, there are significant issues around a large population of people who have prediabetes, but you're right, it's a very heterogeneous population. And the more we can try to target the best intervention for them, the better. In the meanwhile, we need to continue to press hard on the infrastructure that has never been built before for lifestyle in this country. So
absolutely. Yes, it's a yes and.
Yeah, Dean, this is Sherry. Can I ask, is the concern around cost here? And I mean, to some extent, even if, if you have an obese person with an A1C that's 5.8 or something, and you think that they're unlikely to progress, they're still going to benefit from weight reduction on a number of conditions for their health, even if they don't progress to type 2 diabetes. And so I understand from an insurance and coverage perspective that, payers would like us to have a targeted group so that they can cover this. And I do think knowing that is useful. On the other hand, does the consequence of that mean that a bunch of people who would really benefit from this in terms of their health won't get it because we're making it too hard? So I just throw that out there as a sort of a comment.
Yeah, I would say that the cost effectiveness studies of the DPP, and Bill, you should comment on this better than I can, were done on the set of people who had both impaired fasting glucose and an abnormal oral glucose tolerance test. So cost effectiveness has been demonstrated, but it's on a very select population of a subgroup of people with prediabetes. So whether there are collateral benefits to the weight loss and the cost effectiveness of those benefits, of course they're there. I just don't know how great they are, and we're talking about the largest payer being the federal government here. So I think there's also a question of distributive justice and ethic. Is it the right intervention for the right person? And so I think we need to know the answers to that before being able to answer your very valid question.
Yeah, and this is Bill Herman. Just to follow up on that, applying an expensive therapy like the DPP to people who are at low risk and never likely to develop diabetes is probably not a good use of resources. And it's particularly important when one thinks of pharmacotherapies with more potential side effects. You don't want to be applying them to people who, in fact, would never develop diabetes, even if they weren't.
Yeah, absolutely. There's benefit for pharmacologic, issues and side effects. I just sometimes worry about the restriction of lifestyle interventions to patients who clearly need them for their health, whether they would progress to type 2 diabetes or not. The associations between obesity and lots of other chronic conditions.
So there might be effective, less expensive interventions that could be applied to those individuals.
This is Ann Albright.
Go ahead, Ann.
Go ahead, Ann.
What were you referring to?
Can you say that again, Ann? I think you're breaking up, at least on my phone.
Sorry. I was wondering when Dean referenced a large amount of the expenses being paid for by the federal government, was that as it relates to the national DPP?
No, I was raising responding to the concern about will insurers cover the national DPP, and suggesting that a significant proportion of people with prediabetes are covered by Medicare and Medicaid. So potentially those payers would be federal payers. Which is not a bad thing. I'm just pointing it out. We're not talking only about the Aetnas and the U.S. healthcare.
This is Carol Greenlee. I can't tell if someone's talking or not. Is it okay to ask a question?
Please, go ahead, Carol.
Okay, I was looking for this, so I apologize if I missed it, but I didn't see if are you all going to, ask people who put on the programs as external stakeholders, like the YMCA and other entities that try to qualify for running a DPP, what any of their barriers are and what any of their suggestions are for helping them to get these programs up and running? And if you already mentioned that, I was trying to watch for it, but I didn't see that.
We didn't mention that. That's a really good point. Thank you.
I think, this is David, I think the chronic disease directors are particularly active in working with community-based partners, including the Y and other community organizations that provide the national DPP. So I think that there was, some sort of indirect input from the chronic disease directors on those issues, including, what they mentioned about providing administrative support where you've got organizations that have people who are trained and fully capable of delivering the program, but they don't have the administrative infrastructure to deal with, the billing and the management stuff. And so they said that's a piece that could be helpfully provided.
And I've also heard some people say that the cost to them waiting to get to the point where they can be reimbursed is prohibitive. Like they have to do a whole lot of stuff to get approved. And so it might be really valuable to get input from the people who are trying to set up the programs to see what the barriers are. Just an idea.
Yeah. Hi, Carol. This is Ann. Can folks hear me better now?
Yes.
We actually do have a fair bit of data from the delivery organizations because, again, CDC runs the entire recognition program. And then there are, of course, additional barriers if you want to be an MDPP, which is Medicare DPP supplier. And MDPP, again, falls under the umbrella of the national DPP. So we do have significant amount of information about that. It is also why we're taking steps to develop new models, a network model, a more integrated model, where a network can function so that each individual delivery organization does not have to have its own HIPAA lawyer, its own billing capability. And this is a huge area that we are embarking on right now at CDC, and it will possibly be an area of future funding from CDC is to do exactly this. We spend a lot of time talking to our partners and stakeholders and the delivery organizations about their barriers.
And certainly aligning Medicare DPP and national DPP recognition might facilitate program expansion and reduce costs.
Yeah, it would certainly be potential. Anybody who's worked with Medicare has got significant regulatory issues. And so again, maybe that may be some of the recommendations that the Commission will consider because it is, there's more flexibility with CDC recognition and recognition standards, which is for quality assurance purposes. Medicare's CMS's criteria is for payment purposes. And so they have two different purposes, and it's how to best have those line up, but because they serve different functions, they can be incongruent.
Other comments or questions?
Yes, this is Naomi. We have data on how effective, or does the community of patients, do the patients themselves take advantage of all of these programs that the government's supporting? Or is that highly dependent on the individual primary care provider making that recommendation? Because we could develop, excellent programs with great outcomes, but if people don't come, then we won't be as effective as one would want to be.
Yeah,
Amy,
this is Ann. I'll take a shot at that one as well. There are a few contributing factors. One is you look at a number of programs that you have to do with lifestyle intervention and that are longer term because people need a dosage of them. You can look at diabetes self-management, education, and support, woefully underutilized for a variety of reasons. Medicare DPP for both that and DSMT as they call it, really low uptake rates. So again, for the actual organizations that have the ability to make their benefit known or who are in the position to refer, significant efforts should be directed there for sure. There is not a requirement that there be a referral for at least the national DPP, but research does absolutely show that having your physician, nurse practitioner, PA, a trusted healthcare professional, their recommendation for you to engage in the program does increase referral. We are actually have a study underway right now examining that. There is also the issue of what it means to people. You know, does this matter to them? Is it reaching them where they are? So we have a set of experiments going on right now at CDC. We refer to that whole cluster of experiments as in gear. It's increasing engagement and retention in the program. And we are learning a lot of things that have to do with sort of optimizing the behavioral aspects of it, sort of all of the behavioral economics work, things around human-centered design. There's a lot of things that we as a larger research community really should be focusing on as it has to do with habit formation and habit change, which, by the way, we have learned that people do not like to use the word habit when they're talking about these things. So rich area of research, and it warrants a lot more attention. And it's not just for a program like the National DPP or DSMES. It's for any kind of program that requires that people engage in something for more than a short period of time. But it's a really rich area for work.
Thank you, Anne. Other comments or thoughts?
Bill, it's Dean. I just wanted to make one point of clarification regarding my comment about the screening tests. I want to reiterate my complete support for what was put forward around the DPP. So this is not an issue of the efficacy of the DPP or the wisdom of scaling it up. That is an absolute truism. I'm just advocating that we think about the term precision public health, the way that we can apply these kinds of public health interventions in as precise a way as possible. So I just wanted to make myself clear on that.
Terrific. Thanks, Dean. Yeah, that's perfect. We totally agree with that.
And this is Bill again. One final question. I was impressed, based on the data call, the variety of different programs across federal agencies. Has this subcommittee thought about somehow trying to identify the most effective interventions and seeing if they can be implemented more consistently across agencies, much as the way there was one example that the Bureau of Prisons has adopted the DPP.
I think that that's certainly something that our group should look at as we're drawing recommendations from what we have learned from the federal agencies. And maybe what might be helpful is if CDC and our respective federal stakeholder partners identified where we're working together. So I'll just briefly give an example. CDC is working with the VA and DOD on a project related to the National DPP. We have various things going on with HRSA. We have various things going on with IHS. I think it's a question of, and certainly we co-fund research with NIH. So I think it is a question of maybe being more deliberate about articulating those and then getting more directly to your point, Bill, about identifying the interventions that have the best support and evidence and being able to be more deliberative about people embracing those and how best to help them get implemented across the agencies. But that would require that the agencies do come to agreement on the set of interventions that we would really put our efforts behind. And then always how to have options for those for whom these interventions are not yet relevant or are not appropriate for them. But it's certainly something to consider, knowing that there's things already going on in that regard, but maybe there could be some things that would be more deliberate about making sure they're really being maximized.
Great. Thank you, Anne, and thank you, John, and all of the members of the subcommittee. I think we're right on time. Claudette, I'm not sure, or Jennifer, do we have 5 minutes built in for a break at this point, or shall we push on?
10 minutes. You have a 10-minute break built in.
Okay, so why don't we start that now and plan to reconvene at 3:30 Eastern Time, if that's okay with everyone.
Great.
Great. Okay, so we will reconvene at 3:30 Eastern Time. Thank you all very much. It's 3:30, and I think we should get started again.
Jen Bishop, can you go ahead and do the roll call to bring us back together?
Yes, I can. One moment, please. Okay. As we have returned from our break, I'd like to conduct a roll call of the commission members to ensure that the membership is present. Please reply present when name is called. Bill Herman.
Present.
Ann Albright.
Present.
Howard Tracer.
Present.
Barry Marks. Naomi Suzugawa.
Present.
Donald Shell.
I am here.
Bill. Great. Bill Chung.
Present.
Aaron Lapata.
Present.
Ann Bullock.
Present.
Barbara Linder.
Present.
Samuel Wu.
Present.
Paul Conlon.
Present.
Ayatunde Dokun.
Present.
Carol Greenlee.
Present.
David Strogath. Dean Schillinger. Ellen Lee.
Present.
Jasmine Gonzalvo.
Present.
John Boltree.
Present.
Meredith Hawkins.
Present.
Shannon Isaac.
Present.
Shari Boland.
Present.
And Bill Cook. Okay. Well, thank you. There is a quorum present. I will again turn the meeting over to Dr. Herman to introduce the next subcommittee update.
Great. Thank you, Jen. I'll turn it over to Carol Greenlee and Paul Conlon, who will be leading the discussion from the Treatment and Complications Subcommittee.
Okay, thank you, Bill. So I will start off, and then we have some committee members helping us, and Paul will wrap it up. I just want to acknowledge that we have several non-federal special government employees on our committee, as well as Bill Chong from the FDA and Barbara Linder from NIH. I'll start by reviewing our framing statement. Diabetes is a complex metabolic condition that significantly impacts personal choices, affects both quality of life and life expectancy, and requires substantial healthcare system resources. Achieving and maintaining one's maximal potential health status and well-being while living with diabetes requires the availability of appropriate and comprehensive treatment options and the ability of the patient and or caregiver to attend to self-care, self-management aspects of the condition. This requires that the patient and or caregiver, one, have access to and understand information about diabetes, its management, and potential complications. Two, participate with healthcare providers in selecting appropriate treatment options. Three, have the skills, confidence, and psychosocial support to perform the necessary and beneficial self-management task. And four, collaborate with healthcare providers to achieve treatment targets that are consistent with their unique characteristics and goals of care. It also requires that healthcare systems proactively deliver high-quality, individualized diabetes care and support population health improvement activities for the communities they serve. Thus, the work of this subcommittee will identify factors at the person, practice, healthcare system, environmental, and policy levels that facilitate or hinder the delivery and receipt of high-quality care by all persons with diabetes and its complications. As you noted, this framing statement was patient-centered, and it's intentionally patient-centered. Our subcommittee recognized early on that the biggest gap that we all saw was between resources that were already available and getting them to the patient to be used in an optimal way to improve their health outcomes and their lives. So our priorities focus on, or at least try to focus on, what will have the biggest impact in reducing or hopefully closing this gap, and those elements that are supported by evidence and impacted by federal agencies. So last year at this time, we presented our grid. That felt to us like the massive universe of everything in diabetes treatment and complications. And by focusing on the gap between resources and patients, focusing on those items that had supporting evidence and that were impacted by federal agencies, we came up with a priority list. We used this list to come up with research terms for the literature search that we submitted last November, and we used this list to help come up with questions for the February NCC meeting and presentation by CMS, and that was very helpful to us. We sort of built out a scaffold under these categories, and this has had several iterations. We have used this scaffolding to help us target who we wanted to reach out to for information. And as we got that information, we used that information to modify our scaffolding. We then used this as sort of a filter to help us focus on the federal data call to pull out those programs and those policies and other elements that were most pertinent to these categories. The big blue arrow at the side is to indicate that these are not distinct categories. They intertwine and overlap and intersect in all sorts of ways. And I'm going to just share with you, it will be obvious as we present our synthesis, that if we look at DSMES, obviously focusing on diabetes education and support, it also, as we work to improve the access to, receipt, and utilization of DSMES, we're also acting to reduce disparities and optimize individualized care. This also pulls in team-based care and can utilize virtual care. If we look under team-based care, one of the key team members with lots of supporting evidence are community health workers. Obviously, one of their key roles is to reduce disparities and help ensure that patients get optimized, individualized care. This also touches on diabetes education and support, and as we have learned during the COVID pandemic, also touches on virtual care when community health workers were using phones and other devices to stay in touch with their people. And I want to call out one other example, which is something we learned about the VA Department of Defense collaborative pilot on a virtual medical center. And it sort of straddles both diabetes education and virtual care, but also serves to reduce disparities for those who live in rural communities or have long travel distances or work two jobs and don't have time to come in during the normal hours of diabetes education. And it also pulls in team-based care. So this is very very fluid and very overlapping categories. Our external stakeholder call started last December, and you will see a lot of these again as we get into our synthesis, but they focused on getting information around these key categories, including diabetes education, telemedicine, community-based diabetes education. We did both informant calls and requests for written comments. We have been so appreciative of these external stakeholders and all the information they have provided us on the call, as well as the wonderful written information and links that they've provided us. And they've also helped lead us to other important external stakeholders. In addition, we've reviewed the public comments submitted through the Federal Registry notice. Many of these comments have helped guide us, and we really appreciate many of the very useful references that have been provided as well and have helped provide us with additional needed information. We started the federal agency data call with our questions that we submitted to CMS in preparation for their presentation at the February virtual meeting. And then we had a follow-up call with Dr. Jenny Lloyd around her research on DSMT and recognized that we may need to have other calls with CMS agencies again, or divisions again, and in particular the Office of Minority Health within CMS. A lot of the response from the VA has been delayed by the COVID-19 pandemic, but we were able to get a demonstration of the VA Department of Defense Virtual Medical Center, and that was very impressive. We've had a very good informant call with the Center for Drug Evaluation and Research and the Center for Device and Radiology Health within the FDA, both of which were very helpful to us, and we are considering whether we need to have additional calls within the FDA. We've had what I call informational calls with ARC, learning more about these programs, and we're looking very much forward to having full subcommittee calls with them as the National Healthcare Quality and Disparities Report and the Medical Expenditure Panel Survey and Healthcare Cost and Utilization Project help us with a lot of the areas that we are pursuing. We were very impressed with the Digital Healthcare Research Program and have a lot of wonderful links from that program, and we'll probably pursue another call. We've appreciated the written comments, especially those around the U.S. Preventive Services Task Force. We noted 3 pilot projects funded by the Office of Minority Health within HHS, and that were focused on diabetes. And I had a wonderful call, I'm just going to call this out, with one of the recipients of this funding who is now in her 4th year of implementing ways to help federally qualified health centers improve the care of their patients with diabetes. So I really liked the OMH funding, a way to help federally qualified health centers improve their program, and she's showing great results. We also were excited to learn that OMH has a focus on community health workers because that's one of our focuses. And Sherry will talk more about the place-based approach to health initiative that's underway in OMH. CDC, again, has worked a lot in the realm of community health workers, and we've received their report. Also, they have many projects and programs around diabetes self-management, education and support, and we have a call scheduled with them on July 10th. We're spoiled by having Dr. Barbara Linder on our subcommittee, and she's helping with all of our categories to pull out the necessary information and programs. The data call from Indian Health Service was delayed by COVID-19, but we've been able to get some input from some of the diabetes care teams in a variety of different tribal communities, and there's quite a bit of diversity. We were shared one regional survey, and we're very eager to learn more about Diabetes Health Service, which is very exemplar, we have discovered, in many of the categories that we're looking at. The Department of Defense is part of that pilot around the virtual medical center, but we're very interested in their telehealth program for people with diabetes. We have a lot of information we would like from HRSA. We got a sort of brief preliminary written comments, but as you will see, we'd like to learn more. And we have not really reached out to USDA because we have recognized the overlap with the prevention general population efforts around social determinants of health, food insufficiency, food policy, and how it applies to people with diabetes. I'd now like to start turning it over to our committee members who are going to talk about how we've pulled this data together and where we're going with it. And so I'm going to first hand off to Jasmine Gonsalvo to talk about diabetes education and support.
Thank you, Carol. In an effort to inform our subcommittee on the benefits, gaps, and barriers related to diabetes self-management training, we reached out to a variety of stakeholders for additional expert insight. These informants included the Association of Diabetes Care and Education Specialists, the American Diabetes Association, the Endocrine Society, Artis Reed, speaking on behalf of the TMF Quality Innovation Network Quality Improvement Organization, and several other experts. We had the opportunity to tour the innovative VA Virtual Medical Center that includes DSMES offerings. We received written comments from several stakeholder organizations, as well as comments from the public. We've also undertaken a comprehensive literature search relevant to DSMES to inform our work. In addition to this information, we're looking forward to additional essential perspectives from our CDC colleagues, HRSA, and the Indian Health Service. We're excited to hear more about the DSMES work at CDC that Ann Albright mentioned earlier on the call. DSMES has a strong evidence base, including comprehensive national standards, to support its efficacy related to cost effectiveness, improvement in A1C, reduction of serious complications, patient empowerment, and lifestyle behaviors, as well as psychological outcomes. We know that participation in DSMES can reduce hospitalizations and emergency department visits, resulting in significant annual Medicare savings as compared to those who have not participated in DSMES. Although we know that DSMES has a significant positive impact for people with diabetes, it is vastly underutilized. On a national level, only about 51% of people with diabetes ever receive some fraction of DSMES. Indian Health Services see higher rates of DSMES utilization, although they've noted reimbursement challenges consistent with barriers also found in other sectors such as federally qualified health centers. Less than 5% of newly diagnosed Medicare beneficiaries receive DSMES within the first year following diagnosis. This rate is only marginally better for commercially insured people newly diagnosed with diabetes. Perhaps not surprisingly, these utilization rates worsen for minority, rural, and low-income populations due to a variety of factors. Broadly, we're seeing continued worse outcomes in medical costs, even though we know that DSMES could play an important role in improving outcomes and more cost-effective care. The notable barriers identified by our information gathering phase include an inadequate number, distribution, and sustainability of accredited or recognized DSMES programs. Essentially, there are an insufficient number of existing DSMES programs to meet the needs of people with diabetes, and even the existing programs are struggling to stay afloat due to a variety of challenges with program reimbursement and maintenance. The requirements set forth for the provision and reimbursement of DSMES present additional challenges that affect Medicare beneficiaries. These barriers are exacerbated by and themselves exacerbate disparities. This map from the CDC highlights the variable diabetes distribution by counties across the United States. The darkest blue areas indicate the higher rates of diabetes, which unfortunately are often also counties with lower socioeconomic status or income levels. We also know that residents of rural areas have a 17% higher rate of type 2 diabetes than residents living in urban areas. Data from 2016 revealed that 62% of non-metropolitan counties who were less affluent, predominantly Black and Hispanic, with lower rates of higher education and a higher prevalence and incidence of diabetes, did not have a DSMES program. The map on the following slide highlights this disparity well. The darker brown areas on the map indicate non-metropolitan counties with no DSMES programs. There are clearly areas of the country which often align with areas of high rates of diabetes that we saw in darker blue on the previous map who would benefit from increased access to DSMES. Our subcommittee would like to use the information I've just presented to help inform our work moving forward, especially as relevant to the listed federal agencies, including CMS regulations around certified programs and barriers affecting beneficiaries, in addition to the use and implementation of evidence generated from the Quality Innovation Network quality improvement organizations. We'd also like to consider opportunities for improvement for DSMES as relevant to HRSA and FQHCs, the Indian Health Services, VA/DoD, CDC, AHRQ, NIH with opportunities for research on DSMES, and the Office of Minority Health. Our subcommittee is very grateful for the input from our federal and non-federal informants who have provided essential insight to our work thus far. We want our final recommendations to be meaningful and impactful, and we look forward to our continued collaborative efforts. Now we're going to hear from Bill Chong, who will review where we are on diabetes technology.
Hi, thanks, Jasmine. So as Jasmine mentioned, I'm going to talk a little bit about where we are in our synthesis of continuous glucose monitors and other diabetes technology. And so I'll follow a similar sort of approach. We'll go through what we've gathered to date, some of our thinking around the topic, and go on to talk a little bit about where we think we want to go next. So I will. There we go. So as has been mentioned both by Carol and Jasmine, we've had a lot of information gathering to date. Held several informant calls and collected materials from a variety of professional societies, patient advocacy groups, including the Diabetes Technology Coalition, Type 1 Diabetes Exchange. We've had engagement with various federal agencies, including the Center for Devices and Radiologic Health and the Food and Drug Administration, Center for Medicare and Medicaid Services. We've also reviewed the public comments that have been submitted to the Federal Register that Claudette referenced at the beginning of this meeting, as well as received additional materials and references from Juvenile Diabetes Research Foundation. In addition, we started to conduct literature search to identify key references as we look through the benefits, barriers, and gaps as they relate to CGM and other diabetes technology. There's still a few areas that we're trying to gather some additional information on, including from the VA and Indian Health Services and HRSA, as well as from AHRQ. And some of the reasons we're still working to get this information has been touched upon previously by Carol. So here I want to start talking a little bit about why we think this is an area that has potential to have benefit for patients with diabetes. And so on the slide, there's a statistic here on the slide that references the number of emergency department visits in 2016 where diabetes was listed as a diagnosis among adult patients. And it's notable that there's over 200,000 of these for hyperglycemic crisis, and also over 200,000 of these for hypoglycemia-related conditions. And so the technologies that we're discussing, such as continuous glucose monitoring and some of the insulin pumps and some of the newer automated insulin delivery devices, have the potential to really address some of these concerns. So, So among the benefits that we heard of from our various pieces of information gathering included glycemic benefits, talking about improved glycemic control with better hemoglobin A1C, but also reduction in glucose variability and improved time in range. This is associated with not just less hypoglycemia, but also less hyperglycemia and smoothing the glucose curve throughout the day. This in turn has been reported to reduce emergency department visits and hospital utilization. And there are other studies showing that it can also reduce the risk for chronic complications. It's also been reported that there are other non-glycemic reported benefits, and these include things like better fetal outcomes and pregnant women with diabetes, less diabetes distress among patients, increased confidence, and a reduction in the burden of care, both for patients and for caregivers. The other thing that has been coming out more recently is that the benefits seem to span of the broad range of patients, both patients with type 1 and type 2, both children and adults, and also in patients who are on insulin therapy and those without. In a population of particular interest is some of the vulnerable populations, such as those with cognitive impairment. There's still some gaps in what we've gathered to date. We don't have information on utilization of these technologies, understand whether or not there are disparities among patients with diabetes in terms of utilization. We need to have a more robust review of the data to identify long-term and ongoing benefits, and better understanding of the familiarity and knowledge and skill set it takes for the clinical care team to support both prescribing these technologies and supporting them in the chronic use. As we've reviewed the various pieces of information, we've also identified some barriers, and one of the things that has been highlighted in a lot of the comments that we've seen from Federal Register notice has to do with some eligibility and coverage challenges, and one of them is sort of highlighted here, where there seems to be a disconnect in terms of the requirement for self-monitored blood glucose checks and the coverage for test strips, where Medicare coverage limits access to continuous glucose monitoring systems to those who perform 4 or more checks a day, where Medicare typically only covers 3 test strips per day for insulin-using beneficiaries. While it is possible to obtain additional test strips to get more testing done in a day, there are challenges and barriers that make this difficult at times. In addition, there are states in the country where there is no form of continued coverage for CGM. And then another barrier has to do with cost, and potentially changes in coverage could help identify ways to improve this for patients with diabetes, and cost effectiveness analysis and research may be helpful to support those changes. So similar to Jasmine, I'm going to talk a little bit here about potential agencies that could be involved or impacted, and as we think about the recommendations that we want to put forward in this area, just highlighting them for places that we may be thinking about. So I think eligibility and coverage clearly is associated with the Center for Medicare and Medicaid Services. HRSA, IHS, as part of their care for the the population that they care for, these sort of technologies would also be beneficial to their patients. The VA, as we start continuing to gather information from them, and their population of patients having coverage for CGM and other diabetes technologies. NIH, both in terms of funding trials, not just for long-term complications and benefits of using some of these new technologies, but also thinking about what other kinds of research could be useful, such as patient-reported outcomes. ARC and FDA Center for Devices and Radiologic Health would may be impacted as well. And one of the things that we heard on our call with them was that they're already engaging with CMS to discuss and better to facilitate the understanding of some of these new technologies as they're getting approved and go to market. So that is what we have done to date for this area that we think is of value. And I'll turn it over now to Sherry to take us through team-based care and community health workers.
Great, thanks. So first I just wanted to thank Carol, who drafted the slides and helped pull all this together. As I go through this, we've thought about community health workers and done a little bit of a deeper dive there to start with under the rubric of team-based care, where Carol talked about that earlier. So we're in the early phases of this, but right now we have, as Carol mentioned, we had an informant call with the National Association of Community Health Workers, and we got a written report on from the CDC on their Community Health Worker Core Consensus Project, where they list the core skills for community health workers, as well as I'm forgetting the other thing, but they have core skills and some other core projects, and so Ann Albright may tell me as I'm forgetting off the top of my head. And then they have, we had gotten some written materials also from the Office of Minority Health on the place-based approach to health initiatives, which I think dovetailed for when HUD came and talked with us a little bit about on one of our virtual, it was one of our in-person meetings earlier in the course of the NCCC, where they were having people within the different housing locations to help with health. So this is something like that, where they have, for their Jobs Plus program, they choose, they have someone within the housing unit who is a community health worker and focus on health within there. There's also some things around that with IHS that we need to explore as well. From what I recall from the written comments, it was like a 3-year grant, and I think, and Carol can correct me if I'm wrong at the end, but I think they were 2 years into that, so I didn't see the results yet of that, but I thought it was a really interesting program. The public comments we've looked at as well as looked at some of the literature searches. There's a 2015 systematic review on community health workers for managing type 2 diabetes and the different approaches, and then there's been some additional literature since then around what they do. But we're still looking and collecting those. We're investigating additionally in the future upcoming, really wanted to delve a little bit more deeply with IHS for what their community health representatives and their community health aid program providers, to really learn and understand how that's been working, and talk more with the Office of Minority Health, some state-level programs and subject matter experts. So we're in process of information gathering. This slide really just demonstrates the, and I think we've maybe seen this before as a group, but racial and ethnic disparities in developing diabetes. In particular, we know that that those disparities extend to people for diabetes care, glycemic control, and diabetes complications, and therefore sort of an increasing focus on the role of social determinants of health can be a a key way to address disparities, and I know that's part of the rationale for looking at the community health worker approach. So from all of those different programs in our written materials and comments and literature, some of the summary of some of the benefits of community health workers has been, one, addressing the social determinants of health that impact the management of chronic conditions, preventive care, and overall health. Looking at addressing diabetes management issues. So many of these programs have shown improved diabetes knowledge, self-care, improved A1C, and in some studies reducing diabetes-related hospitalizations and costs. And so, again, in a limited number of studies, some cost effectiveness has been shown. The gaps that we've seen in some of these areas so far is just lack of widespread or sustained use of community health workers, sort of underutilization within the healthcare team as well as a social services team is another gap that was identified. Some of the barriers relate to some of these bullets here. So reimbursement is one of the biggest issues. Funding is mostly via, sort of grants, these state innovation models, or Medicaid waiver programs, and so sustaining some reimbursement for community health workers is one of the barriers here for widespread use. Some of the challenges relate to ensuring qualifications. So, there's a desire for certification by people who want to employ community health workers, but I think there's some, by imposing sort of a certification requirement, then it also limits the ability of some community health workers or lay health advisors or promoters. There's different ways of describing them, but it limits some folks from being able to be successful in meeting those certifications, but they would be excellent community health workers. So there's some challenges there. There's currently very few standardized protocols for implementing or using community health workers. There's a lot of variability in how they're being used, and we didn't really find any standard sort of training requirements, so even within the certification programs that exist. So those were some of the barriers to wider use that we've found so far. And then looking at agencies, I think most of these are agencies we are planning to talk to or have talked to already, but these were the ones that we thought were most involved or impacted with these. So I think, CMS in terms of coverage for Medicaid and Medicare beneficiaries, HRSA and F2HCs have sort of variable use of community health workers depending on what's available to the clinic. We'd love to hear more about the Indian Health Services, and we'll find out more about that. And sort of some of the things here, VA doesn't have any standard programs for community health workers that we saw, but we'll have to sort of investigate. They also use peer support in different ways. And then the NIH, we talked a little bit about the idea of looking at implementation science, large-scale effectiveness and uptake, and maybe more around sort of standardized protocols that could be used. And then, the CDC already has some things we might want to explore if they have others besides the Core Consensus Project, and love to hear more from the Office of Minority Health about what they're thinking of with the PATH initiatives and what more is going on there. I know that OMH in Ohio, for instance, supports building out hub pathway models, which is one mechanism for reimbursement for community health workers in Ohio, where patients are referred who have social needs, and then a community health worker is assigned who works with them around housing or food insecurity, and once they have met that need, they are paid for their effort and time. And so that's something that I'd be interested to hear from OMH if they're doing anything more around expanding hub pathway models for chronic conditions. So I think that's all I have to say I'd love to hear others' thoughts once we finish the rest of this presentation. I'm going to hand it over to Paul to talk about next steps.
Thank you, Dr. Golan. So I just have a couple of slides that I'm going to wrap up with regard to some actions that the committee is going to be doing in addition to some of the follow-up steps that you've heard in the individual subgroup and topics that Drs. Gonzalo, Chong, and Golan just presented. You may recall that Dr. Greenlee presented at the beginning that we had originally identified a series of topic areas of which we have continued to explore. One of those areas with regard to virtual care, which we had hoped to explore as an individual topic, we found early on was actually very much a cross-cutting topic, but it also has the ability to be a freestanding issue. Many of you who, as clinicians who use telehealth, have realized that one of the byproducts actually of the recent COVID-19 pandemic is the fact that regulatory agencies such as CMS and many private insurers have actually relaxed their restrictions on use of telehealth, which is actually something that we were seeing as a potential area that needed improvement, an unfortunate byproduct, but to the benefit of patients. We need to collect data on what impacts that has had in people with diabetes. We suspect it actually has been favorable. Specifically, VA has had a robust telehealth program, and we'd love to be able to see some, if there is some evidence on what the impacts of that telehealth program has had on people with diabetes. But one of the double-edged swords to virtual care is that it also has the ability to exacerbate disparities, or at least to unmask disparities. While it may offer advantages to people by providing care in their home without the travel to medical centers, it also reveals the fact that many people live in areas that either don't have broadband access or have limited access, and many people might not have the technological devices to be able to actually access broadband, even if they did have the ability to do so. So this is an area that we're going to be exploring more, and we're going to be forming a subgroup that will have specific interest in looking at the impacts of virtual care and the digital divide. We're also going to be looking at some of the special programs that use virtual care, such as e-consultations and the ECHO program, which developed in New Mexico and has been reasonably robust in its accessing subspecialty care to improve the care of patients in rural sites. With regard to the team-based care program that Dr. Boland just mentioned, although some of our initial work is focused on community health workers, we would like to expand that to include other elements of the workforce, in particular pharmacists, given that there's reasonable evidence that clinical pharmacists embedded in teams provide excellent care for people with diabetes. It would be important to understand what impacts that has and what barriers there may be for further deployment. Specifically within VA, clinical pharmacists are embedded in patient-aligned care teams, and we have reason to believe that that provides benefit in that setting. And it would be important to know whether or not there are other limitations on reimbursement, particularly in federally qualified healthcare centers, about the use of clinical pharmacists. This area of team-based care is also going to be expanded further to look at workforce-related issues and other matters that improve the care of patients from a multidisciplinary, interdisciplinary approach. And then lastly, an area that we had hoped to focus a lot of attention on is the area of reducing disparities in diabetes care, taking the approach that we're not trying to discover whether disparities exist. We accept that occurs just as in diabetes as it does in overall health care. But to see if we can identify key areas or interventions that effectively reduce disparities in diabetes and whether or not those can be more broadly implemented. One of the things that we have uncovered, as I mentioned previously, about, for example, virtual care, is that there are impacts of policies that have what we're using the term collateral damage on patients with diabetes. As an example, given the limits on access to virtual care, diabetes self-management, education, and support may not be accessible to people who have limited access to broadband, come from rural areas, or who have other issues related to their disparities in health care. As the General Population Subcommittee very nicely articulated, we think that there's room to look at the impacts of disparities in health policies as they relate to diabetes, as they outline with regard to the current literature that shows that in fact, it actually does have significant impacts. But one of the, I think, the bigger areas that we need to explore further is the idea of what federal agencies are doing in terms of their data collection. We know that many agencies collect data related to disparities. I think one of the biggest questions is what are they doing with that data, and how can that be maybe better deployed to reduce disparities in patients with diabetes. So with that, I'm going to close this portion of our presentation. I want to thank my co-chair, Dr. Carol Greenlee, for her leadership in bringing our group together, as well as helping us stay on track, and to my fellow subcommittee members for their participation and presentation today. And Bill, I'm going to turn it back to you to moderate the discussion.
Great. Thank you very much, Paul and Carol, Jasmine, Bill, and Sherry. That was an excellent summary of where the subcommittee is. Are there questions or comments from the general membership of the commission? And if not, perhaps I'll start with a question. Carol, you outlined the patient-centered focus and really highlighted the underutilization of proven effective interventions like diabetes self-management education and technologies like CGM and community health workers. I wonder, though, how the subcommittee is going to address the provider and health system factors that really need to be addressed to facilitate linking patients to the resources that they need to achieve optimal outcomes. So in other words, if we make these services more available, how are we going to actually get patients to the services that they need?
I will just say that's evolving. I think we talked about talking with you about that next week, so I'll defer that at this time.
Yeah, Bill, Paul Conlon here. So I agree, a relevant topic that needs to be explored further, and my sense is that that's likely going to be an area of development in our team-based care community health worker program as that expands. That's probably the best area that such a topic would fit.
Great. Other thoughts or comments? I don't know this group to be reticent. Does anyone else have anything they want to bring up or discuss?
This is Anne. I would just say that I think you guys have done a really thorough job of approaching this. I think the ways that you're looking at the categories you're focusing in on are really great. I just wanted to commend you for that and appreciate that. And we at CDC are eager to have this upcoming conversation with you and anything else we can do, because it's such an effective intervention, DSNES, and one that just needs to be much, much better utilized. So I really appreciate that.
Yeah, we're really looking forward to that too. We're very excited about it. So thank you.
Thanks, Ann. Other comments?
Ian said we can't hear him, but he's asking about the elephant in the room, price controls, especially as the new diabetes agents are shown to be effective and are very high cost. And Dean, it's really funny that you chatted that in because I was debating whether to say anything about that for discussion. We did have some significant discussion about medication costs, both insulin and newer agents. Clearly, as they address more and more, the newer agents are sort of showing benefit in cardiovascular and kidney disease. Also, will that heighten the disparity that we see as we relate to cost in patients? So I think we did have some discussion about that on Wednesday. I know we have a lot of topics to cover, and I think there's also, a question of how that best fits. So I think we've discussed it. I don't know that we have an answer right now. I know, Paul, you talked about maybe the potential of making, having Medicare, would Medicare be able to negotiate for their own, for their formulary or for the medications to help with drug costs as a potential. The question is, what can we recommend that would actually be taken up? If people have thoughts, I think we'd be open to hearing them, but Carol or Paul, you may want to say something more.
This is Carol. I'll say we're well aware of that. We talk about it often. We recognize that people can't get the medications that we think might optimize their individualized care, and that creates more disparities and helps or worsens outcomes that could be better because of cost. What limits us is it's such a huge problem way beyond diabetes. It's such a politicized problem. We don't know how to really address it from this commission because it's so big. And we did talk about that on our recent subcommittee call. We think that a lot of the things to do with diabetes, if you would look at it from a cost effectiveness standpoint, not just the cost of the device or not just the cost of the drug, but look at the whole cost across the care of the individual, including reduced development of complications, which drive a lot of cost, let alone human misery. ED visits, hospitalizations, et cetera, these things would be cost effective even at their high cost, but the cost is outrageous. And we know that there are 3 bills right now being submitted for the cost of insulin. But, I mean, even, everything that we've talked about today needs like a cost effectiveness analysis because nothing that we talked about today is really adequately supported, but would offer huge benefits to the people living with diabetes. And if we look way beyond A1C, even more benefits. So this is, how do we get that kind of attention for the total picture paid to diabetes, the way it was for hepatitis C when those really expensive drugs came out. It seemed like every payer agency noticed right away that the cost of the drugs, even though they were outrageously expensive, was less than the cost of a liver transplant. And so everybody, even Medicaid, was paying for them. And I realize those are 8 or 12-week treatments, not lifelong treatments, but we need that kind of look at diabetes. Sorry to go on about that.
This is Ann. Have you guys looked into the recent policy change at CMS and the president, of course, held a Rose Garden announcement of this in lowering the price of insulin, really all forms of insulin, for Medicare beneficiaries. I think it's $35 a month, if I'm not mistaken. Have you guys looked into that, any limitations of that, or hopefully commercial plans can follow suit? Of course, they can offer their lower price, but they can't offer it for any higher. So wondered if you guys would explore that at all.
Well, we've looked at several articles on it, and we have a lot of concerns that those savings are going to be offset by increases in premiums, deductibles, et cetera. So we are looking at that, but we're looking at it broad. I mean, we're trying to look at, are they going to take it, out of somewhere else? So, and then there have been a lot of publications lately saying that it's not just the cost of insulin, it's the cost of everything for people with diabetes. But yeah, we're trying to stay up with that.
Well, it may be the recommendations that come forward may be a way to try to protect that or make adjustments in that. Because goodness gracious, we've all been working on this for quite a while. Particularly those of us who've used insulin for the vast majority of our lives, and to see what has happened to the price. My team has done a couple of economic studies on insulin, and of course, it raises issues around who is actually footing the bill versus those who are actually saving the money. If you have insurance, it's a very different story than if you don't. So if we can be helpful in any of those papers to the degree it helps you guys at all with that question, we're happy to share those.
That's really good to know. Yes, thank you for that.
Yeah, and if you have things that you want to share by email, I think that would be really helpful just to make sure we have everything. But I do think that it's more than insulin. It's the GLP-1s, it's SGLT2s, and when you talk about medications, and so I think thinking about a broader issue around that. And Carol, as you mentioned, of course, there's all sorts of, cost things with diabetes, but I think the medications is a big one if you're looking at disparities in cardiovascular effects.
This is Ann Bullock. Just want to thank you guys for your presentation, and also and that you mentioned Indian Health Service several times, and thank you for understanding that our response to the federal data call has been caught in the COVID storm that has hit IHS as well as, of course, many other places. But I do look forward to the opportunity to talk with you all about Indian Health Service's approach. We are a really interesting case study in what happens when you remove cost from the equation for patients in an under-resourced system like ours. We can't always afford all of the newest, most expensive drugs, but let's also not forget that metformin has many of the same benefits as some of the newer drugs, not identical indications, et cetera, but it no longer, of course, has a particular pharmaceutical company pushing it forward. Just in the last couple of days, we're seeing metformin might even cut COVID issues, at least in women with diabetes. So anyway, look forward to talking about our community health workers, about our ability to take care of people over the lifespan, whether they have insurance or not at different points in their lives, how important, we love, great control, but really good control, or at least, reasonable control over the lifespan is even more important than short-term bursts of, good control with, than long periods of not good control. So our ability to take care of patients regardless of insurance is also very unique, and our ability to have some impact on drug pricing, et cetera, et cetera. So look forward to talking with you all. I think our system has a lot of lessons to show, including the outcomes of reduced prevalence, reduced kidney failure, reduced eye disease of diabetes. So anyway, just wanted to throw that all out and look forward to being able to share some of our lessons learned. Thanks.
We look forward to it as well. Thank you.
Great. Well, thank you again, Carol and Paul and the entire subcommittee. I think we need to move on now. And we do have some time allocated for oral public comments. We have 4 speakers today. Each of the speakers will have 3 minutes to address the Commission. And we'll go ahead and start with Jean Drummond.
Very good. Good afternoon, Commission Chair Herman and members. First, I would like to commend Dr. Albright and the team and her team and the work of her team. I am Jean Drummond, President of Healthcare Dynamics International, a GPP CDC pending certification organization. I'm a clinician driven by the power of policy and economics in a value-based care delivery environment. With over 30 years of experience serving patients, clinicians, health and community-based systems serving vulnerable communities, HCDI understands the complex social needs that impact patient outcomes and ultimately drive higher healthcare expenditures related to diabetes. We began our DPP journey in July 2019, leveraging over 15 years of experience delivering culturally and linguistically appropriate diabetes self-management education programs with qualified clinical staff, yet it has taken over 9 months to navigate the federal and state requirements to deliver services. We are interested in the hub and spoke models of care recommended earlier to share our administrative infrastructure with less developed DPP. In light of our clinical community experience, my recommendation includes the following. 1, streamline the current certification process across the different delivery models, not requiring additional applications for each model. Align Medicaid and Medicare programmatic goals and payments. For example, the minimum of 5% weight loss is incredibly challenged to achieve and maintain in light of rising social determinants and cultural diversity norms. Reduce the length of time before the DPP provider is considered fully recognized to permit Medicare billing. Essentially, a DPP must have 1 year of full operation before billing to permit, which is our current status. Include community health workers as a member of the DPP workforce to support the much needed and trusted support and tracking. Increase DPP-based reimbursement considering all aspects of setting up and operating a program, such as the multiple calls required to recruit and retain the most vulnerable patients, not to mention the onerous daily biometric dating. Consider the risk-adjusted payments for DPP serving vulnerable populations. In light of the COVID-19, these factors are further magnified as we must quickly adapt to address the gaps in computers, Wi-Fi, and broadband in both vulnerable communities. Eligible clinicians serving these populations often have limited resources and are not able to provide these educational services. Finally, in summary, we request the National Clinical Care Committee to put forth recommendations that risk adjust for vulnerable populations so that patients such as these can have improved health outcomes and a better quality of life. Thank you so very kindly.
Great. Thank you very much for your comments. The next person we have is Kate Thomas. Turn it over to her now.
Hi, I'm Kate Thomas with the Association of Diabetes Care and Education Specialists. I'm here today representing the Diabetes Advocacy Alliance. The DAA appreciates the many opportunities we've been afforded to engage with the Commission, especially in your data collection efforts and through the work of the subcommittee. Since the Commission last met, COVID-19 has upended life for all Americans and has raised specific concerns for the health of people with diabetes and prediabetes. As we've learned, the health complications of COVID-19 are more severe in people with underlying conditions like diabetes. New research also suggests that COVID-19 and diabetes may be a two-way street, and that COVID-19 may trigger new cases of type 1 and type 2 diabetes or possibly a new form of diabetes. We have also seen unprecedented changes to healthcare delivery modes that have increased access for many individuals and opportunities to make permanent many of the waivers that have been issued, such as those expanding telehealth. Despite improved access for some, the pandemic has also underscored the stark disparities that exist in our current healthcare system. We've talked about diabetes health disparities for years. Now is the time to do something about these disparities, and that means addressing social determinants of health to help us achieve health equity. We must look beyond statistics and focus on the socioeconomic and environmental factors that continue to exacerbate health disparities. We urge the Commission to continue to focus on the role of social determinants of health in improving health outcomes and to develop final recommendations that support interagency collaboration to achieve health equity. Also, as we evaluate the effects of the pandemic on people with diabetes, we must consider the role of existing Medicare benefits in preventing diabetes and mitigating the risks of diabetes complications. The DAA has addressed barriers to these Medicare benefits in our previous comments, but in summary, we urge the Commission to recommend that Congress address the following. Increase utilization of the Medicare Diabetes Prevention Program by aligning MDPP requirements with those of CDC's National Diabetes Prevention Program. Explore options to expand Medicare coverage for medical nutrition therapy to include individuals with prediabetes. Remove barriers to accessing diabetes self-management training services. Recommend regulatory reforms that would allow CMS flexibility to cover innovative diabetes technologies and services. And remove existing coverage barriers to diabetes technology, like eliminating the 4 times per day testing requirement for continuous glucose monitors. Thank you for your consideration of our remarks today. Our written comments will be forthcoming and will address these topics in more detail. Thank you.
Great. Thank you very much, Kate. Our next commenter is Kate Curley. Please go ahead, Kate.
My name is Dr. Kate Curley. I am Director of Chronic Disease Prevention at the American Medical Association, and I'm making these comments on behalf of the AMA. We welcome the opportunity to provide these oral comments, which represent key points from our written comments submitted to the Commission on February 3rd. The AMA addresses prediabetes screening and management in collaboration with local and national health, government, and community organizations. This work has included developing and implementing clinical strategies and tools to increase prediabetes screening and referral to evidence-based treatment. To address these clinical gaps, the AMA developed 3 prediabetes quality measures for which we are seeking inclusion into Medicare and other payment programs. The COVID-19 pandemic has heightened our awareness of the critical need to prevent the incidence of diabetes. Studies have shown that individuals with diabetes may be at higher risk for complications and a more severe course of illness if they contract COVID-19. Preventing type 2 diabetes requires a multi-layered approach that addresses social, economic, and environmental factors as well as individuals' health behaviors. In addition to societal and cultural barriers to lifestyle behavior change, there are many factors that limit physicians and care teams' abilities to deliver effective preventive care, such as the lack of consistent insurance coverage for evidence-based preventive interventions like the National DPP Lifestyle Change Program. Also, physician practices frequently lack the infrastructure to systematically identify and connect patients to interventions that extend beyond the traditional clinical care environment. HHS should consider several specific policy changes that will improve the delivery of diabetes preventive services, including modifying the Medicare Diabetes Prevention Program by eliminating the one-time benefit provision, covering all program delivery modalities, including virtual and online, aligning program length and lab values with CDC national DPP standards. Under Medicare Part B, expand coverage of hemoglobin A1C testing to include screening for abnormal glucose metabolism. In addition, under Medicare Part B, expand Medicare coverage of medical nutrition therapy to be a service covered for people with prediabetes. There are many federal agencies that address and promote lifestyle behavior change to prevent type 2 diabetes. The AMA urges the Commission to align the agencies to create a mechanism that supports ongoing research and promotion of interventions that demonstrate improved outcomes. The pandemic clearly demonstrates the need to accelerate working together across many sectors like never before to improve the health of the nation. Thank you.
Thank you, Dr. Curley. Our final commenter is David Moskowitz.
Hi, I hope you can hear me.
Yes.
Oh, great. So I really only have 2 comments. I am founder of Genomed, a genomics-based next-gen disease management company. Essentially, we use molecular medicine to try to improve clinical outcomes. 25 years ago, I told Andy Narva, who was the chief nephrologist for the Indian Health Service, about my data at the St. Louis VA showing that I could reverse diabetic nephropathy if I used a high dose of quinapril. And the IHS and the VA and actually CMS, who I visited in October of 2004, and the NIDDK and the CDC showed absolutely no interest in abolishing 90% of dialysis because the same approach works well for hypertensive nephropathy. The second point I have is that a month ago, a group of us published a case report showing that quercetin, a plant flavonoid that is over the counter, is a specific inhibitor with high affinity for the mast cell MRGPRX2 receptor, which seems to bind the viral nucleocapsid in SARS-2, COVID-19, as well as other viruses, and may in fact be a universal viral antidote. I presented data on this kind of thing to the White House OSTP in 2003, but was shot down by Fauci at that point, who believed that only a vaccine would be appropriate for viruses. DARPA and BARDA were interested, but now I see that BARDA is spending billions of dollars on vaccines as well. In other words, it's hard to come up with solutions when the healthcare system seems pretty adamant at not accepting them.
Great. Thank you very much for those comments. I want to thank all four of the presenters today for their comments, and certainly invite further comments and recommendations from the general public. We, as was mentioned, have digested many of the 84 comments already provided, and certainly would invite further comments about agency contacts, key informants, particularly relevant literature, and any thoughts related to cross-cutting issues, including health equity, social determinants of health, as well as research needs. So again, thank you very much. And I think this now brings us to a discussion of next steps and closing remarks. I want to thank all of the commission members for their hard work and comprehensive presentations and thoughtful questions today. I think we've shown a huge amount of progress over the last few months, and I think that the future directions were pretty clearly laid out. So I look forward to this high level of engagement and the continued subcommittee work to move the agenda of the Commission forward. I'll stop at this point and actually ask Clydette or Rick or Jen if they have any comments, and then whether any of the subcommittee chairs have comments as well.
This is Jennifer Bishop, and I don't have any additional comments. I just want to continue to thank the Commission for all of their hard work and the progress that they're making towards our ultimate goal.
Any other final comments from any of the Commission members? Good. Well, I want to thank everyone for their engagement and attention today, and certainly look forward to the continued work of the Commission. Thank you all very much, and thank you for the members of the public who've commented and called in today. We appreciate it.
I would like to just reiterate Dr. Herman's statement. We thank everyone for their participation and hard work. This meeting of the National Clinical Care Commission is adjourned. Everyone have a great evening.